and official members of the society, Professor Natarajan, President of the Tele-Ophthalmology Society, and its members, delegates, friends, ladies and gentlemen. I warmly welcome for this morning session. First, I would like to thank the organizers of this meet and the past president of the TSA and the architect of today's meet, Dr. Professor Ganapathy, giving me an opportunity to talk on the untapped potential and promoting telemedicine in Tamil Nadu. The history is very important, most important, because we've been fighting for this for the past more than 2 decades. So I thought, I would just briefly touch upon some history before going in. The Telemedicine Society is the main organization, and it has got several chapters, state chapters, about 12 chapters so far in every state. But we are trying to increase the state chapters to almost all the state. But at present, we have about 12 chapters, and these are the important chapters which really does a lot of work. Like, for example, today's meeting is being done by Tamil Nadu chapter. So even though the TSA was formed about 10 years back, and even though we were all the telemedicine as such, Tamil Nadu was the pioneer. In fact, starting the telemedicine program 2 decades back, and we were the first to have the tele-CME between 4 countries, Singapore, Australia, Japan, and that was the first CME program in the whole country. And of course, Professor Ganapathy conducted the first teleconsultation program in Aragonda Apollo Hospital. These are all history, but now we have gone far ahead, and so what we are today is something different. Slide. 4 years ago, I'm sure most of you would remember, we had the first telemedicine meet, which was held at same Dr. M.G.R. Medical University. And this was supported by our university along with the Tamil Nadu Society of Telemedicine. And this was very successful conference where all the deans, principals, nodal officers of the Tamil Nadu government attended. And this was a full day conference, and more than 100 delegates participated. And this conference gave such an impact to revamp telemedicine program in many government institutions, an eye-opener for many government institutions. We also gave the government a complete report regarding the revamping of telemedicine activities in government medical institutions, with budgeting also at that time 4 years back. Slide. Tamil Nadu government received the highest award from the President of India, from Shri Pranab Mukherjee in 2017 in Delhi at the International Conference for the excellence of promoting telemedicine activity in the country. This conference was an eye-opener for the country, which emphasized the importance of telemedicine and its value not only for the public, but for the army, where they introduced several telemedicine notes were given to the high altitudes for helping the army people, and several lives were saved in these notes. Telemedicine has 2 important roles. As you all know, that one is the teleconsultation and second is the tele-education. With regards to teleconsultation, major institutions in India like Apollo, Ramachandra, Shankar Nethralaya, Arvind Eye Hospital, AIMS, SGPGA, Lucknow, Kochi, AIMS, and several other government institutions are doing very well. And of course, we still lack this particular service in many villages and taluks and some district hospitals. But I'm happy to say, for the last 2 years, thanks to COVID, we are able to achieve more than 100% satisfaction in teleconsultation, both in government and private institutions. But what is worrying is 2 important issues. One is the standardization and interoperability, which is very important to avoid medical legal issues. I'm sure the speakers, the next speakers will be talking on this, because these are 2 important aspects. And if these 2 important aspects are still not taken up very seriously, we can get into a very serious problem, especially on the standardization procedures for telemedicine to avoid medical legal issues. Coming to teleeducation, the main reason having this conference in this university today is to discuss and improve tele-education. I think more than tele-consultation, I feel tele-education is very important. As you all know, more than 400 medical colleges are interconnected by excellent broadband through NK Knowledge Network and also by satellite connectivity, thanks to ISRO. Unfortunately, we are not able to utilize completely to our satisfaction in this network, and only 30% is being used for education, and only some of the major institutions are using for tele-education like CME, Grand Round, Workshop, Conference, Telesurgery, etc. And institutions are almost doing, these are some of the institutions like Apollo, Ramsel. Of course, they're all having CME regularly and they are being doing the CME programs continuously, giving to other institutions. Slide. Thanks to Government of Tamil Nadu, today almost every district has got a medical college today. Almost, I think every district will be covered very soon with a medical college. And I feel the best lectures and workshops were given by the senior faculties in cities are not being partnered with the district hospital. This is something which is very, very important. If we are able to achieve this in coming years, this will be something very, very important when we think of one exam, one certification in coming years, I think throughout the country. And we expect some sort of standards uniformly to be taken. And I think this is possible only through telemedicine. Fortunately, during the COVID, many institutions started online classes with available bandwidth at a cheaper rate provided by the government, and more utilization has to take place on these areas. And many private institutions are ready to provide CME to the government institutions if it is requested. Slide. Of course, I'm just putting these slides so that these are all histories which I'm not going in. Telemedicine Society and Tamil Nadu chapter regularly conducts many conferences and workshops at state level to promote telemedicine, not only for medical education, like dentistry, nursing, allied health sciences. And I'm very thankful to members of the society for taking this as very important matter. Slide. TSA is very much was involved in the Pan-African e-network project for telemedicine, where we were able to connect 53 countries of Africa from India. About 11 major institutions participated, and these lectures were given, including teleconsultation, to all the African countries. And this was very much appreciated by the African Union, and where the students could retrieve these lectures anytime, and these are all archived by the server. Our institution, Ramachandra, has done more than 4,000 CME programs, both national and international institutions, and for both conference, workshop, live surgery. And this is probably as an important mandatory being a university for NAC and UGC, etc. I request the officials of Tamil Nadu M.G.R Medical University to take a strong view on this aspect in coming years. And I'm also happy to say from this year to be covered, and we are also covered by the insurance company, and they're accepted for teleconsultation as a revenue model. Slide. These are all something very important slide where you could see what are the chapters done so far. Many chapters, we almost do 3 or 4 conferences from each chapter, and Tamil Nadu has done extremely well. In fact, I'm happy to say that 2 PhD students we had created from our university. One finished about 2 years back, and we have one more PhD guy who's sitting opposite to me. She finished about 4 years back. And this is something very, very important. And for education purpose, these are very important. And I probably request all the institutions to come forward to do more work. Of course, the robo was something which you saw some slide, which is introduced long time back for telemonitoring of the ICU. But unfortunately, due to some technical issue, we're still not able to get back to the newer version, which we are trying. And this was inaugurated by the past president, Dr. Abdul Kalam at that time. All these programs are being done by the chapters at various levels to create mainly the awareness among the institutions and faculties so that more telemedicine activities are taking place. Right. I would also like to thank the government. This is a VAT. We do regularly see how many students are participating, and these are all taken in the VAT where we went about a few years back. And we still continue to go to many engineering colleges and make the awareness about telemedicine. I would like to thank once again the government of Tamil Nadu, Dr. M.G.R. Medical University, for helping us for improving the telemedicine activity, for taking us to the next level. In fact, a few months back, I had given a complete report on how to improve telemedicine with our present health minister, and he was very keen to hear, and he has promised to take it up, especially for education. I spoke to him. He said he will have definitely a meeting with all of us very soon and take up to next level. I would like to thank once again the Vice Chancellor of the esteemed university, officials of the university for viewing this as a very important subject to discuss. And I would like to thank all the organizers of this meet and giving me this opportunity. Thank you very much. Thank you.
Thank you, Professor Sandakumar. I would request Dr. Ganapathy, Senior of the Telemedicine, and Sir is the Director of Apollo Telemedicine Networking Foundation, and he is also a honorary distinguished professor of the Tamil Nadu M.G.R. Medical University. The next session is on, in fact, that's the first session, is on the basics of telemedicine. I request Dr. Ganapathy to chair this.
Thank you, Kumar. I think this is very important, understanding the basics of telemedicine. And I'm delighted to introduce you Dr. Dheeraj Krishna, Head of Telemedicine, Star Health Insurance. As you know, insurance can make a significant role in enhancing the utilization of telemedicine. And I think you've got the most appropriate person to talk on this. Dr. Dheeraj, unfortunately, you have exactly 600 seconds in which to cover your entire message. Thank you.
I think it starts with. She's starting.
Yeah, Dr. Sheila John also.
She's starting this. She's talking.
Okay, fine. Sheila John, Head of the Teleophthalmology Unit, Shankar Netralia, Teleophthalmology, and Dr. Sheila John really require no introduction. She's going to talk on the brief history of telemedicine and to be followed by Dheeraj Krishna.
Thank you, sir. Good morning to everyone. My topic is basics of telemedicine. Although it's a very topic which you have to understand, history, definitions, and mode of communications. I'm from Shankar Netralia. Next slide. The history of telemedicine is the history of telecommunications. And if you see, the first thing which was formed is telegraphy, and then after that telephone, and then came the television, and then internet, and then the internet, and then NASA. After that came the Indian Space Organization. Next slide. Now again, the history of telemedicine, the technological development is very important. Video cameras progress in imaging telemedicine, especially radiology, pathology, and first it was done in Norway in 1990. Later, ISDF, through trials in functional telemedicine, new trials in functional telemedicine, cardiology, neurology, psychiatry. 1995, development of telemedicine networks. Next slide. The pilot project of telemedicine started in India. It was by the Indian Space Organization. I'm sure Ganapathy sir would be able to tell. The first one was done by Apollo Hospitals in a village called Aragonda. It was initiated by President Bill Clinton. And that was the first telemedicine thing which was done. The Indian Space Organization. Next slide. The Indian Space Organization covers various states and tribal regions, and many hospitals have established telemedicine due to the Indian Space Organization. Next slide. Shankar Netralia also established his teleophthalmology unit in 2003. Now, due to the COVID pandemic, the government and the board of governors brought in telemedicine practice guidelines in March 2020. Next. Which brought in a lot of definitions for telehealth, The delivery and facilitation of health and health-related services, including medical care, provides care to patient education, health information services, and self-care via telecommunications and distant communicate technologies. Next one. Now, telemedicine, the patient and the doctor are separated by distance, and all healthcare professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment, and prevention of disease and injuries, research and evaluation, and for the continuing education of healthcare providers in the interest of advancing the health of individuals in their communities. Next one. Now, what is a registered medical practitioner? A registered medical practitioner is a person who is enrolled in the state medical register or the Indian medical register under the Indian Medical Council Act 1956. Now, the mode of communications, according to the mode of communication, where to take it can be video, audio, text. Video is telemedicine facility. Videos on chat platforms, Skype, Skype. Audio is phone. Text-based telemedicine chat-based applications specialized on smartphone apps, WhatsApp, general messaging, text, chat platforms, Facebook, Messenger, asynchronous like email, fax. Next. Now, according to time of information transmitted, there are three types: real-time, audio, video, text interaction, store and forward asynchronous exchange of relevant information, and remote monitoring. Now, real-time video and audio text interaction during video and audit for exchange of relevant information for diagnosis and medication. Next slide.
Hot water, hot water. Hot water. Yeah, I think so. Yeah, I can take it. Download. Yes, I. Thank you, Dr. Sheila, for giving us a brief history of telemedicine. I think you are going to talk. You spoke about what has happened till now, and I want to talk a bit more of what we're planning to do now and for in the future as well. I think just 1 second. My slides. That's the mic.
So, participants not here.
Oh. Thanks. Okay, so I'm here to speak about bandwidth and mobile health. And before that, I would like to talk. I would like to thank Dr. Madam Sudha Seshan, Vice Chancellor of Tamil Nadu Medical M.G.R. University. And I would also like to thank Dr. Sunil Shroff and Dr. Sendil for organizing this event and all the other dignitaries on the panel. Yes, so as mentioned, I just want to talk more about my topic that's about bandwidth as well as mobile health. So to start with bandwidth, I think Dr. Sheila had given us a chronological picture on how bandwidth had evolved when they started with the extended C-band of the satellites, and now how it has come to broadband and where we are today. And I've just given a brief of it. We started with telephone, then came SATCOM. After that, we had dial-up internet. Then came in 2G, Edge GPRS, and we are today at 4G, and we are also waiting for imminent release of 5G in the Indian subcontinent. Yeah. The crux of telemedicine, right? And I think Dr. Sheila had put it in a very good way. There are two major forms of telemedicine. One is asynchronous, and the other one is real time. In the real world scenario today, asynchronous telemedicine, probably the usage is close to 10%, whereas 90% is more of real time interactions. So bandwidth is the king in this scenario. So what are we doing for that, right? I think there is a multi-pronged effort from various industries to improve bandwidth, not just the healthcare industry, but from the other angles as well. Private telephone carriers have been actively increasing the volume and penetration of mobile networks and its availability. Also, 5G is planned to be launched in India by October 2022. Again, I think we are looking back at the skies again. Now there is the new platforms such as the Tesla Starlink, as well as Telesat, which are looking at low orbit satellites, which can beam internet, high-speed internet across the globe, and that would increase the availability of network tremendously. Also, a lot of latest telemedicine softwares are enabled with high compression video codecs, which enable compression of the video at the site, and also uncompression or expansion of that file at the end of the receiver. So through low bandwidth, we are able to relay high definition videos today. I think my next topic is on mobile health, and I just want to give a brief, idea of where we started. We started with a huge bus with a satellite dish on the top, and today we have reached a scenario where we have our entire telecommunication model on our mobile phone. We are able to have video consultations on the fly. We're able to have chat-based consultations on the fly. We're able to relay multiple medical parameters through this, such as ECGs and connected devices, which are helping with, and that was in the last year where we were suffering from COVID pandemics. We had pulse oximeters, which could relay the messages, which were connected to Bluetooth for your mobile phone. They were relaying, real-time information on the entire patient monitoring systems. I would also like to say that the TPG, the Telemedicine Practice Guidelines, has opened the gates for mobile health, and many video consultation platforms are available. And for example, WhatsApp is offering FaceTime, Zoom, Skype. All these platforms are used today for providing teleconsultations as well. And there are also some very specific, security protocols which are followed, such as HIPAA, GDPR, and etc., which are followed by these major platforms, which are offering that literally free of cost today. And also point of care devices, again, they are a great boom today. There have been days where people had to go to a hospital to get an ECG done. Today, a person who's having a cardiac issue can have a tele-ECG monitor at home. They can connect it to their mobile phone and then get their ECG transmitted to their cardiologist at the flash of a moment. The same applies to point of care medical testing devices, such as, which are able to do blood tills, multiple panels of blood tests with just a prick of their finger and a drop of blood. So I think I just wanted to touch upon this, and I would like to hand it over to Dr. Sunil. I think in the next 20 minutes, he's going to give us the complete idea of telemedicine practice guidelines and how someone can start and implement telemedicine services based on the guidelines.
Thank you.
Thank you, Dr. Dheeraj. I'd request Dr. Mohan Rajan, who is the president of Tamil Nadu Ophthalmic Association and the chairman of Rajan M.G.R Hospital, to chair the session. And
good morning, friends. I think it's really a wonderful concept which has been introduced now by Dr. Sunil Shah and Dr. Kamalasan Sendil for this telemedicine conference or webinar, I would say. And I think it's the current concept, which is picking up, especially in the post-COVID crisis, the pandemic, what we are facing here. And it's also very important that we have all stalwarts, like Sello Kumar, Dr. Ganapathy, Dr. Sheila Jan, who's my classmate in Madras Medical College, and Sendil, Natarajan from Bombay, and a very good friend of mine. And I'm very happy that Tamil Nadu, as the president of the Tamil Nadu Ophthalmic Association, we are also taking up this ophthalmology to every nook and corner of Tamil Nadu. And I'm very, very glad that we are associated with this conference. To introduce Dr. Sunil Shah is, I think, taking hold to Newcastle is the man who was really known for telemedicine and also competent urologist as well. And he is also a very socially conscious person. I have not seen a more dedicated medical professional. It's really a great opportunity and blessing for all of us to be outside with you, sir. Thank you, sir. Over to you, sir.
Thank you and good morning again. So I'm going to give you an overview on telemedicine practice guidelines. The guidelines were passed by the Government of India last year. And I think
think COVID-19, one of the indirect benefits has been the establishment of telemedicine in the country. It has also shown some lacunas, what needs to be done next, but I think we've done extremely well in this time. Guidelines were passed last year and subsequently gazetted in May. Like this code, because we have been struggling for 20 years to get these guidelines through. And Waldman said that there are decades where nothing happens and there are weeks when decades happen. And I think that's what happened last time. In the COVID times, of course, was a great blessing, and I'd love to hear from our health secretary what he's got to say. The Tamil Nadu was spearheading the program using telehealth in a big way. And teletriage, was great, through telemedicine was a great benefit for COVID care to segregate the cases, the surveillance, getting the oxygen bed, ICU bed, satisfaction, so many things. And I'm going to briefly cover all this about the guidelines. The guidelines itself, the laws that apply to telemedicine in India, some gray areas, some privacy and data confidentiality issues. So the purpose of the guidelines has been that to use telemedicine as part of normal practice, gives practical advice to doctors. It's an enabler of your practice. It's not a separate tool. Don't compare telemedicine with traditional care. Traditional care is always going to stay. Telemedicine is going to just be a tool. And it provides regulations for safe patient and provider care. It does not allow for consultation outside India. It doesn't prohibit you, but it's not covered. Does not allow for research. Does not allow remote surgical procedures. Does not cover hardware, software, and so on. There are 7 elements in the guidelines, and every doctor, every RMP needs to be familiar with that. And these include, in the context of telemedicine, the identification of the doctor and the patient, mode of communication, what are you going to use, as Sheila was saying, going forward, or video consultation, consent process, type of consultation, patient evaluation, patient management. What is the context of a suitable situation? It is left to the doctors to decide, RMP to decide if a given circumstance is suitable for teleconsultation, then he proceeds. If he finds it's not suitable, then they should go for in-person consultation. And the standard of care should be the same as face-to-face consultation within its limitations. This is what the guidelines say. So what you can do with this is provide counseling services, provide health education quite easily using it, prescribe medication as well. There's a list given by the government, prescribed. And you can use it for prevention, diagnosis, treatment, education, as I said. You can do monitoring at home with all your devices. So many devices are available today, otoscope, ophthalmoscope, neuroscope, everything. Almost neuroscope is not there, but it soon come, I'm sure, Dr. Ganapati. ECG monitoring and, this great STEMI example of, hub and spoke model where you can, use thrombolysis in an acute ST elevated MI has saved many lives. Many great examples. You need to identify the doctor and the patient because the patient can falsely present themselves. That's why identification is important. And also, we must remember that many doctors who don't have qualification, almost WHO report says 57% of doctors in India don't have qualification. So, identification of doctors is equally important. And that's a must. Mode of communication, Sheila has already told you to be synchronous mode or asynchronous mode. Synchronous will be video chatting and video consultations and so on. Asynchronous will be email, SMS. And when you combine both synchronous and asynchronous, you get this hybrid, the software applications, which are going to really, that apparently 300,000, apps available on healthcare out there. And this takes care of a lot of pain points like login, appointments, history taking, document uploading, consent, prescription, payment. So this, is the way forward. But every specialty may have a different requirement for an app. So if you ask me which app to use, I may not be able to give you a straight answer. Consent needs can be either implied or it can be, explicit. Implied is when a patient walks into your clinic, it is implied that the patient wants help. In that situation, you just, register the patient's, request of consulting you by putting in the register, and that's about it. Whereas an explicit consent is something else. Explicit consent has to be taken it as a caregiver, or if there is a caregiver, or it could be a doctor, it could be a nurse, it could be a relative. If they are consulting on behalf of the patient who is not able to give consent, then in that situation you require an explicit consent which needs to be documented. from the patient. The patient can just say, I agree, that's all, or he can just mark a tick. And that's an explicit consent, and that needs to be recorded. So this is what I was saying earlier. It could be verbal, it could be SMS. You just say, yes, I consent to avail, and this should be done. And there are two types of teleconsultation, the first consult and follow-up consult. The first consult is patient consulting doctor for the first time, or patient has consulted earlier, but more than 6 months have elapsed before the previous consult, or the patient is consulted earlier, but for some other condition, then it becomes a first consult. Or the doctor can call. So these are very clearly outlined what is the first consult, and you must understand what it is. And second consult is if you've done a follow-up consult and you want to see the doctor, then you can also follow-up consult. But if you've done a first consult with the video, there is no provision, that's the rationale, no provision for a follow-up consult with video. That again, you have some first consult. Prescription of medication, list over-the-counter medication, all medications are prescribable. This A includes ointments, drops, follow-up consult medications. And then follow-up consultation medications can include for blood pressure, for hypertension, for asthma and others, etc. is used. So that's left to your imagination, but you need to be safe. And you can also use, because mental health was a big problem, so they have given some more medication, including phenobarbital and clobazepam and so on. This B medication are follow-up medication, which you can add or you can change the medication when the patient comes to you after they have done a in-person consultation. And there is a prohibited list of Schedule X drugs which you cannot use. When you're prescribing medication, you should ask for allergies, you should take the same precautions. Yeah. Sure. So prescription, you have to use precaution, and you need to ask allergies and so on. And what is important is you need to have a diagnosis or at least a provisional diagnosis before you prescribe medication. Otherwise, it will be considered as something which is not in the interest of the patient, and that you can be in trouble for that. And e-prescription can be transmitted, provided you take permission from the patient. You can scan it and transmit it. In an emergency situation, you can save a life by giving first aid, but it is best for the patient to go to the nearest doctor or hospital. But you can give assistance, like, as I said, like if somebody is bleeding, you can control by putting a tourniquet and so on. Fee for consultation can be charged just like normal, but don't charge anything exorbitant. Health insurance companies like Star Health Insurance is now reimbursing your teleconsultation. The growth profile in the last 18 months has been tremendous in India. We're doing 20 million, with 10 to 20 million teleconsultations so far. Doctors we have found are mostly from Tier 1 and 2 cities. Patients have been from Tier 2 and 3 cities. There's been spurt of consultation in rural areas. First-time women consulting has increased. First-time people over the age of 50 consulting has increased tremendously. So the laws that cover telemedicine practice includes our Indian Medical Council 1956 Act, which was amended in 2002. That's a very important act to know. Drugs and Cosmetic Act, Clinical Establishment Act, and Information Technology Act. And in the EdTech Act, there are 8 chapters. And at least in 4 chapters, chapter 1, 2, 3, and 6, telemedicine practice guidelines apply, directly or indirectly. You need to maintain a digital trail of whatever you've done, your documentation, including the certificates if you've issued any. So it says it is incumbent on RMP to maintain a following records and hard copy of the documents for the period prescribed from time to time. And this has been about 3 years for indoor prescriptions. So we also say it should be 3 years. And what you need to keep for record includes phone logs, not the phone audio itself, email records, chat or text record, video interaction logs, including consent. This needs to be preserved. You don't need to record the whole video and keep it. If you want to keep it, it's for your safety, but you need to keep a log. That's all you require. Many times we are asked this question. And of course, all the images, diagnostic data and all, which are utilized for teleconsult, if you keep that, good. All prescription records should be kept. Now, the standard of care, the RFP says the same standard of care needs to be face-to-face consultation, but within the intrinsic limit of telemedicine. Standard of care has not been well defined. It's not explicitly defined in the guidelines, and the interpretation can be ambiguous. Why I say that? In the court of law, if something goes wrong, if the standard of care has been met or not, will be determined by the trier of the fact, not by the doctor. And standard of care depends on your professional experience, your knowledge of dating, and no two similar cases, conditions may be aligned. So the scope of practice and limitation of telemedicine needs to be better defined in the guidelines. This is the first thing. About privacy and confidentiality, digital consultation will leave an electronic footprint and prone to issues with security and confidentiality. Because video consultation can never be 100% confidential. There can be patients involved in that. So that needs to be also taken care of. And we need to see how to protect. The informed consent, many times when you download an app, and you said, I accept, that you never read the whole long jargon which is there. And it's in a convoluted legal jargon. Nobody reads it. So the guidelines specify that patient consent is necessary in filing consultation, but it does not mandate the collection of patient consent for processing, storage, or transfer of patient medical record. This is where the data privacy and confidentiality issue comes in. As far as advertisement is concerned, to inform is allowed in any advertisement, to persuade is not allowed, and to remind is again allowed. The RMP saying that telemedicine guidelines says do not solicit or advertise or give inducement for teleconsultation. The RMP should not insist on telemedicine when the patient is willing to come for in-person consultation. But we do see a lot of editorials, we see photographs in print medias, but nobody has ever been prosecuted. So we require to have amendment of our act, which will give us more clarity on what is follow-up consult after first video consultation, more clarity on standard of care, list of safe drugs need to be spelled out, more clarity on advertising, published of photographs of doctors need to be also taken, talked about. So video consent, more clarity requires on privacy and confidentiality. So now it's called National Medical Council, the new medical council. The ethical practice laws will require changes, and all state medical councils will need to have machinery to implement it, and we'll need to create an IT grid of all the state medical councils to keep track of doctors' qualifications. So this is my last slide. We've got to know what is the future of health post-pandemic. I think digitalization of public health will grow. Is he here? Our health secretary? I'm finishing anyway.
No problem.
Digitalization of public health will grow for disease monitoring, disease prediction, and for prevention. Consultations and digitization of data provides a great opportunity with better patient engagement, satisfaction, and great efficiency in the system. Telemedicine is here to stay. Hybrid form of care would become the new normal, believe me. It's not going away. But to keep the ecosystem safe, we require to have an independent oversight committee that has both regulatory and implementation role. Thank you very much. I hope this was useful.
Thank you. Thank you.
Despite all the interruptions.
I understand there's a slight change in the program. The health secretary is here, and so the inaugural function will take place. After that will be the next session.
Just have one question, one medical legal aspect.
What about
If
it?
there are any questions, please.
Yeah, what medical legal applications of telemedicine? What are the areas?
So it actually doesn't, there's a lot of discretion given to the RFP to decide what you can do and what. And as a practitioner, if you think any time that you need to see a patient in person, to give a diagnosis and treat, after you evaluate the patient, you can always refuse a teleconsult. As an RMP, I think we cannot be beholden to that. We need to use this as a developer, like for diabetes retinopathy.
Yes, sir.
Using it for a screening tool is great. But with a remote diagnosis, if the diagnosis is in doubt, it's always better to call the patient for in-person consultation and have a look at the fundus yourself. I'm just giving an example. Yes, okay. But diabetic retinopathy is a huge, big area. Screening is required for diabetic retinopathy because we don't have enough knowledge, the word. at least grade 3 and 4 in property should be immediately taken care of to prevent blindness, but that is the biggest, the most common cause of blindness in the world. So I think there are, ways by which you can protect yourself. And at the same time, whenever you're in doubt, just call it out. So far in the 20 million consultations we've done in the country, we've not had any issues. But believe me, some stage something will happen, or worse, it's bound to happen, and then there may be a knee-jerk reaction and the whole ecosystem will. So to prevent that, that's why we're recommending that it's time that we come out with telemedicine practice guideline number 2, in which we define the standard of care within the limitation of telemedicine and spell it out. Like in South Africa, what they've done, they've said that when there is in-person consultation not possible, in that case, you can do remote consultation.
Can we get this?
Please. Thank you.
Morning. My request to all of you, this inaugural session, let's not go by what is there in the program because the secretary will have to leave immediately. He's come.
We'll do a short welcome, madam, and then.
Let him.
Yeah.
You can finish. There's a minister's meeting. It's part of it already, the meeting is bigger than his speaker is here.
Morning, sir. Morning. Shall we welcome you, sir, for 2 minutes? So, on behalf of the Executive Committee of Telemedicine Society of India Tamil Nadu chapter and our members, it gives me immense pleasure in welcoming our Health Secretary, IAS Dr. M.G.R, Madam Dr. Sudha Session, Vice Chancellor of Dr. M.G.R Medical University, all the distinguished guests in the room, and all the listeners out there. We welcome you on this little rainy morning in Chennai, but it's not too bad. The weather is holding. And I'm so happy, sir, that you were able to make it. I know you have so much of engagement, especially with all the floods that are happening. But telemedicine today is here to stay. Tamil Nadu has done some tremendous work during COVID times. I think we use telehealth for, tele-triage, case surveillance and so on. And Tamil Nadu has been a pioneer in this area. The society itself is Telemedicine Society itself is a society with 900 members, 12 state chapters. And soon after the pandemic, we started short courses for doctors on how to practice telemedicine. And we are so far since 25,000 doctors. Since you're in a hurry, my one request is, with your help and with the help of Madam, we should try in Tamil Nadu to get these courses accredited. These are all online courses, safe-learning courses. My request is, humble request is, get them accredited and help us in promoting telemedicine in Tamil Nadu. That's the theme of this conference. So let's, with your kind of help and, we can promote telemedicine. We have such talents in the room who have been, grandfathers of telemedicine in India. Dr. Kanapati, Dr. Selvakumar and others, Dr. Sendil. He's a company, which is very successful in teleophthalmology. Professor Natarajan from Bombay, Professor Mohan Rajan and so on. So they're all stalwarts. So kindly help us in getting these courses accredited and let us train all our doctors to how to practice telemedicine so that this ecosystem can be saved. Thank you very much, sir.
A very good morning to everybody. First of all, I would like to thank University Madam Dr. Sudha Session, Madam, for organizing this important function in the university premises. To give a statement that telemedicine is something which we all work together. Of course, Dr. Shah, Dr. Mohan, all of you, each one of us distinguished, and all the participants who are here will directly come to the challenges which we face. One is pre-COVID. See, telemedicine is something which none of us can actually argue about the utility. Pre-COVID, I have been associated with health earlier as DC Health in Chennai Corporation 2000, then as Corporation Commissioner, then subsequently from 2012, of course, as collectors, we work in we have access to challenges, access to areas which have challenges. Whether it is, a corporation like Salem has Kolattur, where you do not get adequate doctors and all, and of course, Kalra and Hills. So many challenges are there. We have seen as collectors and face those challenges. And when we come back from 2012 onwards, along with Dr. Gita Viswanathan Madam, and subsequently, after that also, I've been associated. Pre-COVID times also, nobody disputed the utility, and everybody found that the challenges of providing doctors and state-of-art care in remote areas of Nagapattinam. Say you look at Kudiyakari, or for that matter, many such places, Viluppuram, everywhere people accepted it, and it definitely made. Of course, ophthalmology, the team is here, and I have myself seen the kind of diagnostic and treatment areas where you started intervening. That was one side of it, and everybody accepted the importance, and we used to also at the highest level talk glowingly about the need for expanding telemedicine. Of course, even both synchronous and asynchronous kind of interventions of telemedicine are all talked about. But post-COVID, it is during COVID, let me say that it is too early to say it is post-COVID. During COVID, that really hit everybody. The need to provide services, the need to reduce personal contact, the need to bring in the quality of the diagnostic facilities which you have. All this, the policy changes which accompanied the COVID times really has actually given them, unfortunately, there are all challenges convert themselves into an opportunity. This is one area where this is a very huge opportunity which was utilized at all levels. If you look at Government of India, E-Sanjeevani, or though I will not say that it is at state of art treatment, but in health and wellness centers we have consultations, and again, apart from this directly telephonic consultation started coming in a very elementary way from outside the hospital within the hospital. And also when you look at the COVID started getting expanded throughout the state to other places where we didn't have the latest advances of pulmonologists or the other complications, now mucormycosis. So these things, apart from simple phone or visible smartphone kind of conversation, it also went much beyond it. So I personally feel this is the right time that all of you, particularly the Telemedicine Society of India, organizing the theme. It's slightly unfortunate that administrators, we have not been able to give the real kind of fillip. That is why you are still coming putting it as the untapped potential. I said, look at NHS. Now people who are working at NHS in off time, they go and do the entire radiological report and give. Here also, it is not that they have not tried. A lot of radiological studies are analyzed and then sent back, apart from direct kind of interventions which telemedicine give. So, and similarly, counseling services, so many potentials are there. And in fact, remote surgeries being guided through experts outside. So the potential is really untapped and not just a theme of the particular hybrid program which you have done. And having said that, I also feel that we all need to move on. On in the senses, I'm not talking about the doctors and all, regulators. If you look at now, you have the challenge of people doing degree outside, but they are, and whenever they have done the remaining part of it online, the regulations of NMC has not permitted many of them to really get back into practice. So, like you rightly said, on the regulatory framework, similarly on the education framework, I still feel we should be progressive in decision making, because ultimately now the lack of skills is what is challenging everybody. So the more we promote access to skills, I find the struggle of an MBBS doctor once he finishes, he actually is confused. Even though so many more PG seats have come, diplomas have come, and dependent courses have come, still he is unable to decide because of the reduced number. People have some, so this telemedicine and probably even courses in telemedicine will also help him. Ultimately, what we need is skill in medicine. I've always said on two areas we all need to focus, and my association, personally as a veterinarian who has done my post-graduation in genetics, I continue to be associated with a number of research activities on the animal health side. Even though I am now in administration, I personally feel the challenge is in translational medicine. See the kind of quick research to deliver. Again, COVID gave that opportunity to fast tracking approvals. So this is a time where people are willing to compromise and willing to understand that we need to compromise these kind of regulatory mandates. That is one. Second is on telemedicine also, we need, like you say, on the courses, we work closely with the university because ultimately it is a question of academic council and a number of things. But how do we integrate them? Because I continue to feel, I continue to say that many fellowships, many hybrid training where you actually practice is ultimately going to benefit the people at large, because ultimately we need services with not only qualified people but skilled people. So that is where I think this telemedicine gives you a huge kind of opportunity where you can really transport the competent people. And the final suggestion would be having a list of empaneled people, whoever is willing. That is what we have been trying pre-COVID also. But ultimately, during those times, we used to talk about it and we used to symbolically also achieve. Look at Zawadi Hills, look at Sitteri, look at those areas we have made. It is not that we have not made attempts, but we have not made it in a sustained way or in a substantive way, translating such symbolic achievements. We have acknowledged everything. We have all acknowledged that it has given huge results. Of course, looking at post-accident Tnmgrmu, MRI scan and CT scan in a very elementary way. And now we are talking more about the treatments and all. So these are all huge opportunities. That is why the word untapped potential is very apt for this particular meeting. And very honestly, knowing race, knowing so many challenges, still, I could have also joined on within Chennai itself in a neighboring room, put a virtual meeting. I felt that this is too important a meeting for us not to acknowledge it and do a very distant kinds of presentation or give a last minute excuse. You all would have excused me, but I didn't feel, I felt it is much better. I'm very thankful to Honorable, our most respected Vice Chancellor. She has always been, even now in this short while, I could see the kind of research she has supported and the kind of popular articles she has supported. Last request is all of you are already doing it, but I still feel more and more foray into popular journalistic presence by people like you will make the access much more easy for common people to understand the advantages. And final request is doctors also, if you come back with a telemedicine report, should be converted enough not to seek a fresh thing in a neighboring lab, neighboring scan center. So that attitudinal change also they need to have, because when you talk of HMIS, when you talk of telemedicine, you all need to understand the cost of medicine is what. Their breast cancer drug when I joined was 45,000 an injection. It has come to less than 50,000 an injection. Cost of stent test. People want that translation of the reduction of cost come down. And ultimately, it is a win-win situation because we can, so many, one side you have an untapped potential, another side you have an untapped amount of people waiting to get themselves treated for many chronic ailments because they can't afford it. The only government is free. Sometimes access to government is a challenge, and sometimes the facility skills are a challenge. So these all will form part of the untapped potential. We are all in very safe hands because very, very experienced people have joined together. I think you all can guide us and send us a report, which at the administrative level I will act on the education side of it and the teaching side of it and the courses side of it. I am sure you are in safe hands, madam. Thank you one and all for giving us this wonderful opportunity to interact with you.
Thank you.
And I just took my comments on permission and Dr. Ganapati. In 2002, we started a course with Anna University, a 6-week certificate course, the first in South Asia. 6 batches we ran. Unfortunately, they were too far ahead of the time. It's 2002. We couldn't give employment opportunities. Now there are several companies which are looking for trained people. And sir, the course content is ready, the syllabus is ready. Madam, 3 of your predecessors, I have spent hours and hours with 3 of your predecessors, but well, maybe the times are not appropriate. In 3 months, sir, we can get 2 months, we can give you a full detailed syllabus, course content, faculty, that on to minute areas. We really think the time is opportune now, and there is enough demand for a diploma certificate, even a degree in telehealth. I'm associated with SGPGI, which is the National Institute of Telemedicine and Biomedical Informatics, is a resource center promoted by the Government of India. They're running courses there. My humble request, Tamil Nadu are pioneers, and in 3 months we can give you the entire course content for this thing. There are so many regulations to be done, and we would encourage you to please consider your decision, certificate, diploma, degree, whatever it is.
We'll take it forward, sir.
Not to see. Help us. We are ready with it.
Details are taken forward.
One more request, sir. Don't think depends on budgeting for education in government, sir. Budgeting has to be separately done. Most of the important chapters like Udsa, Lucknow, they all have a separate budgeting for television in government. We need one special nodal officer on a doctor basis who will take up the issue with the doctors. Because we are all private people. But there must be one chapter. We are all interested in telemedicine. That's the reason why we are here, sir. There must be some person, need not be by name. Person will keep changing. There must be one special nodal officer from the government side. We should meet.
No, anyway, M.G.R. who is doctor, incidentally also a qualified medical professional. Technically, he is the nodal person, because government of India has rolled out e-Sanjeevani, it has its own contribution, but definitely, be honest enough that, so many interventional contributions which you are going to talk about, and so many, that is a tertiary level contributions, definitely we can do. We'll definitely get it integrated based on whatever you do, just send a 2-pager or a 3-pager report. And requiring action points at various levels, you share it, we will definitely.
There is so much of district hospital, new hospitals coming. These lectures, which are so many 400 medical colleges are interconnected with the NK network. I think all these lectures must reach the district hospital, and they should all the students.
The accident itself, just because of lack of orthopedician, a neurologist, or a specific neurosurgeon, you have to. But probably after immediate scan or MRI, somebody on tele can say that, actually there is no serious bleeding. He can be, or somebody is having a serious, he's otherwise talking about to collapse, quickly refer him. Those kind of lot of decision making will point where they can be.
The president of Telecom Society, my talk is on blind free Tamil Nadu. So I actually told the president of Tamil Nadu.
You were talking about it.
We want to clean all the diabetics in there. Using the non-medical people. And we have a course from Skill Development Corporation, India.
Sir, I come from Anna University. I teach computer science. I know Mr. Ganapati for quite some time. He was mentioning in 2002, medical instrumentation course was started. A course on telehealth would help where exactly can technology meet medicine.
Correct.
And
Thank
we
you.
have a very good hub.
Thank you, sir, because audience are waiting for listening to the lectures. So let's not make this a forum of representations to the secretary.
So all your points will be taken, and I will interact with both Dr. Raman and you, Dr. Shah, and we'll take it from.
Thank you, sir.
Very good. VC's initiative is very good. Let us stick on to the program.
The microphone is sensitive.
Okay.
No deviation from the agenda.
Full screen, good.
Full speak la poitu TNMgrmu very good. ஆமா very good. The next meeting is sir.
I don't need to.
Chairperson, because sir, sir is the chairperson.
I'm speaking, madam. I am the speaker now.
Oh,
If you could spare a few minutes, I'd be very happy.
No, I don't care, sir.
If you can.
The entire thing is out in the open. That's why certain things.
Come now.
Correct. Shall I start?
Yeah.
Good morning. We have a great session today on reducing a warm effect, and we have a Dr. M.G.R. to talk about it. One of the pioneers for healthcare. He is director for Telemedicine Networking Foundation and Apollo Health Services. He's also the past president of Telemedicine Society of India and former secretary and past president. He's already told me not to read his resume, so we train from that. And we're going to have a really long session of telemedicine. Wow, I will keep this.
Good morning, everybody. It's indeed a privilege to share with you some of my thoughts on what I have learned in telehealth over the last 21 years. The venue of this conference being the temple of learning, I think it is most appropriate that I start by paying homage to all our teachers, and particularly when the Vice Chancellor of this university is a scholar. Sadashiva Samarambam, Shankaracharya Madhyamam, Asmadacharya Pariyasam, Vande Guru Paramparam. This is a tribute to all the teachers, but for whom we would not have been here today. Most of the sessions on telemedicine deal with technical aspects, connectivity, you talk about regular software, hardware, and so on. And today we have to take it for granted that telehealth is going to be a part and parcel, is going to be integrated in the healthcare delivery system. The Apollo Hospital Group, one of the largest in this part of the world, have formally announced that treatment outside hospitals is going to be the future of healthcare. I think a huge group like the Apollo Hospital is not be spending their time in building more hospitals, acquiring more hospitals, but instead will be spending their time in making satellite units everywhere. So this has to be accepted. I would like just to very quickly review the process of telemedicine. The word patient is going to be changed with the term beneficiary, and the term doctor is going to be changed with healthcare provider. We are going to use telehealth not just for diagnosis and treatment, but even for keeping patients well, promoting health the e-way, promoting wellness the e-way. This is going to be the future. Most lectures, 90%, 95% of conferences on telemedicine concentrate on hardware, software, acquisition of images, storage of images, how do you retrieve, how do you display. We talk about orientation, training, customization, making it cost effective, developing a business model for it, how do you comply with regulations, self-sustaining, to be future ready, and so on and so forth. We talk about configuration of systems, make telehealth chamber absolutely attractive. I'm going to spend time on all these details on how to configure your microphone, how to have a camera. I think an additional web camera will be more useful. Often forget that the person at the remote end looks at you as a doctor. For centuries, a doctor has been associated with someone immaculately dressed, well dressed, wearing a white coat and having an air of formality around. Telehealth implies that this has become totally informal. Anyway, I put it to you that it is essential that we retain a formality. For you to achieve what I call the wow effect, the room from which you give a consultation must be adequately lit. There has to be a good background. I'm not going into minute details. All this is freely available. But please remember, in 5 minutes or 7 minutes, the person at the other end is judging you as an individual, judging you as a whole. They're not interested in whether you have a PhD, whether your papers published in your name. That is not at all important. You need to get into the mind of the beneficiary, and this is what I'm going to talk about. Where the tube light is placed, the location of the speakers, the keyboard, the mouse, every one of them is important. COVID has totally changed the way in which we look at telemedicine. I was amazed to see hundreds of papers literally published on ethics in telehealth, the double-blind, randomized, control studies, Cochrane group, etc., which very scientifically compare on what happens from the patient satisfaction point of view. I would like to take this opportunity, though Indian telemedicine is second to none, we are unfortunately nowhere with respect to the other countries so far as publication is concerned. The time has arisen where we need to objectively produce evidence, solid evidence, evidence-based medicine. I need data to prove to the health secretary, to prove to the health minister that we have indeed made a difference in every way. The single most important thing of my entire talk is that clinical use of telemedicine. Ladies and gentlemen, I belong to the DC era. I'm not talking of before Corona, I'm talking of before computers. I was the last neurosurgeon in this country who was trained before there were computers in a hospital. We were taught to listen to a patient, examine the patient physically, make a clinical diagnosis, and then only use technology. Clinical judgment is absolutely mandated. And the telemedicine practice guidelines, I'm delighted, has observed this, and they have very clearly mentioned again and again that everything is contextual. Please understand that medical, legal, regulations, etc., everything is contextual. It depends on the time when you give the teleconsult, with whom you give, who you are, what is your background, etc., etc. The right decision at the right time. The simple, most important word to me is contextual. Body language on a screen. We are so, we spend all our time filling up EMR, hospital information systems, paperwork, etc. We forget that the person at the other end is evaluating you. He does not have your score. He does not have your CE. And therefore, body language is critical. Please spend 5 to 6 minutes getting into the mind of the beneficiary, take away everything else, concentrate on the patient, look at him. And if you think that you require a professor to judge you, you're absolutely wrong. In my opinion, neurosurgical practice for the last 45 years, and having given at least about 3,000 neurological consultations in the last 20 years, I have found it is a so-called illiterate person who is the most sophisticated of the lot. People judge exactly whether you have established rapport with him. Empathy, sympathy, all this is very, very important. Each patient is a universe of one, is a universe by himself. When I had my training in the 20th century, it was assumed that the doctor knows best. Today, ladies and gentlemen, the doctor is also involved in the decision-making process. A patient who comes to me has already consulted Professor Google and Professor Facebook, and believe me, he knows almost as much as I know regarding the management of cerebral arterial malformations. I love this word website. All of us, at least people of my generation, were thrilled with the bedside manners of our teachers. Among our teachers, we were so impressed with how they just put a hand on the abdomen of the patient, they looked at his pulse, looked at his face, and you would see the patient looking at the doctor almost as God Almighty. So this has to be done today. This can be done. Technology is an enabler, and there are so many articles published on website manners. And scientific studies have shown that people with good website manners impress the patient much more. It is not 5G, it is not 1 Gbps bandwidth, it is not the resolution of your screen was important, but purely you and you. About 10 years ago, I met Dr. Kamulini Ramdas, a professor at the London School of Business, and we discussed the possibility of shared medical appointments. I gave her my inputs. I never really thought this would continue, and today, even the American Psychological Association are using group therapy using telehealth. I foresee that in the years to come in India, after all, a doctor spends at least 60% of his time on counseling, telling the patient general things which are more or less the same for all those suffering from the same illness. Why should I spend 10 minutes telling a diabetic on lifestyle modification? Why can't I get hold of 10 diabetics together and talk to all of them about lifestyle modification? This would considerably reduce my time, increase my availability, reduce the cost, and so on. Therefore, from a mental point, you need to get prepared. We were all taught that patient confidentiality. We were taught doctor-patient relationship is sacrosanct. Scientific studies today have documented that a patient is happier, is more than happy to share, is willing to share notes with his fellow sufferer. Quite often the compliance and adherence becomes much more. And I foresee this is going to be a part of telehealth. People, process, and technology cannot be viewed in isolation. This is like a Venn diagram. There is an intersection of all the three. It is something very personal. It is not e-commerce. It is not ordering a pizza online. It is not buying a ticket for your air ticket or your train ticket. It is very hard to feel that your experience was excellent when those treating you on a screen do not introduce themselves or make eye contact or say what they are doing to you and why. This is very, very critical. Now, here you can see what Mayo said 150 years ago, and I think it's very apt today. Patients don't care how much you know. They only want to know how much you care for them. I repeat this again and again. Your knowledge is not at all relevant. It's you are displaying virtually how much you care for them. Give one well-trained physician of the highest type, and he will do better work for 1,000 people than 10 specialists. I'm very fond of Sir William Osler, and I have taken a few quotations which I think are very relevant in today when we are trying our best to promote telehealth. The practice of medicine, ladies and gentlemen, is an art based on science. It is not science per se. The old art cannot possibly be replaced. It has to be absorbed in the new science, not replaced. Medicine is an art, not a trade, a calling, not a business. A calling in which your heart will be exercised equally with your head. If it were not for the great variability among individuals, medicine would be a science. We need to know what is it the patient wants, understand what the patient wants. Mother Teresa is symbolic, and I think that telemedicine is slowly getting dehumanized, they're getting depersonalized. And I would like to once again emphasize that doctor-patient communication is critical, particularly when you do it virtually. The importance of non-verbal communication. Many papers have been published which show very clearly, and you can see a few papers quoted here, including from the Cochrane Library. Meta-analysis has been done, and this has shown that people prefer doctors who communicate with them. These are all solid scientific studies. 80% of messages are conveyed non-verbally. This is not my conclusion. This is the conclusion of articles published in international journals. Conveyed through body posture, voice intonation, the way one looks, the way one sits, your attire, the movement of your hands and arms, spontaneous smiling. I remember when I was in school in the 1960s, Voice of America said, if you see someone without a smile, give him one of yours. These small things are very critical, and I think this and this alone will produce the wow effect. 93 randomized controlled trials to 22,000 participants showed that the outcome with teleconsultation was no different. It was not better than, but no different from that in a face-to-face consultation. This, I think, is solid scientific data. Unfortunately, we cannot extrapolate this to Indian conditions. And I once again beseech all of you, let us do studies like this. Let us prove with data from Tamil Nadu, with data from northeastern India, that teleconsultation is actually better, or at the worst, certainly not worse. We need solid scientific data. Doctors need to be formally trained in etiquettes of telemedicine. Technology enhancement only improves rapport. It does not reduce humanization. Telemedicine and in-person consultation, the face-to-face consultation, should not be considered as divergent. We should make them converge. In other words, telemedicine, according to me, is just augmenting an in-person consultation. Now, our personal experience, we today do almost 13,000 teleconsultations every day for the last couple of years, mainly through public-private partnership projects with various state governments. But again, in private practice, 90% of the teleconsultations are follow-up consultations. I don't for a moment suggest that telemedicine, remote healthcare should replace face-to-face consultation. The clinician in 2021, if I were to write down what are the requirements of a clinician, he should be a combination of Shushruta, absolutely skilled in surgery, the compassion of Mother Teresa, the pragmatism of Lord Krishna, what he told us in the Bhagavad Gita, the battlefield of Kurukshetra, the genius of Albert Einstein, again, the understanding of what the public wants. Steve Jobs said, Steve Jobs' success in the Apple phone is not technology, but catering to the needs of the consumer. Of course, if you need to do all this, you have to be a superman, but that's what you are. This, ladies and gentlemen, is my last slide. It has been a wonderful journey for me personally from 1998 onwards, and today we should not be talking of compliance, regulations, rules, laws, clinical medicine. I think that if telemedicine is to grow exponentially, it is not the telemedicine practice guidelines. It is not even developing a business model. It is not even having passionate people like you. You would not have been attending this program, but for your interest in telehealth. The only person who's the brand ambassador for telehealth is the beneficiary. The beneficiary should say, wow, what an effect. Look at that doctor. I never realized that he was not sitting by my side. Can you believe it? I saw him on my smartphone, and every little doubt I had, he answered me. Wow, I'm going to tell my family, I'm going to tell my neighbor, I'm going to tell my friends. This, in spite of all the digital marketing you do, in spite of everything you try to do, this is the only way. For this to happen, you need to develop. This is not a typographical error. You need to develop trust, and trust. Absolute trust between the beneficiary and the healthcare provider. This alone will make telehealth an integral part of the healthcare delivery system in the country. I could go on and on, but I can see the chairperson looking at his watch, and so I will stop there. Thank you once again.
Beautiful, sir. What a tremendous passion is there, so much energy, and people out there need to learn anything from you. And a fine morning like this, it's keep the sleep, but if you're speaking, there's no chance to sleep for the rest of the day.
Thank you, sir.
Absolutely brilliant.
Thank you.
I tremendously enjoyed that.
The panel last.
Brilliant answer.
We can break for 5 minutes.
5 minutes.
The question.
You can get all the.
Last audience, virtual audience.
Are there any?
For the virtual audience, I will be pleased to attempt to answer them.
Are they able to chat? Can chat more?
They can hear.
They can hear.
Speak minute.
Yeah.
Audience, you have a brilliant opportunity to get the insights of one of the earliest people in this country.
Anybody?
Sir, I want to ask one question. You are I would say, the father of telemedicine.
No.
Grandfather, whatever it is, like, because I have listened to your.
The grandfathers.
I have listened I have listened to your lectures long time, even 15 years back in a conference and on telemedicine, and you have seen it right from the beginning, the infantile stage now to the adolescent or adult stage, whatever it is. So what do you think is going to be the future?
Sorry, what do you think?
Going to be the future? How it's going to be more accessible?
I am very optimistic. I'm very optimistic. See, unfortunately, they are hypocrites. I think that unless there is incentivization, which is the term Americans use, unless there is vitamin M, an incentive, a disincentive, a carrot and a stick. A carrot is much better. The US is a classical example. Once Medicare, Medicaid, United Health, all insurance companies started reimbursing telemedicine, the graph went up like this. I mean, you can't expect doctors to be philanthropists all the time.
Yes, sir.
The COVID pandemic, I mean, I'm not going to charge for a consultation, certainly not. But there has to be a business model. And today, I'm very confident. 10 years ago, the major problem we had was in such a simple thing like collecting the money and giving the patient 800 miles away and take it to the doctor here. Today, with my plumber and electrician, I saw somebody on the road selling flowers on the pavement. And I was shocked to see somebody in a scooter coming down, taking the flowers. He took out his mobile phone, and then there was a QR code by the side of the flowers. He scanned the QR code, and this lady says, I've received 25 rupees. I mean, digital payment in India, nowhere in the world do they have digital payment in India. So I think that is a tremendous sense of progress. Once doctors are reimbursed for consultation, it will take place. But as I said, sir, I'm a 20th century doctor. Technology is a means to achieve an end, not an end by itself. A fool with a tooth is still a fool. You still need to practice tender loving care. You still need to get into the mind of the doctor, beneficiary. What is it he wants? And use technology for that. I'm concerned that today's doctors are so fascinated by 5G or 1 Gbps bandwidth. Yes. Resolution. They're so fascinated. They don't see. I, as a doctor, I mean, I can do a 2-hour lecture on cerebral arterial malformation, but I need to understand what the wife of the patient wants. She may not want treatment.
Absolutely.
So I need to cater to that. That part is going away, and if that comes back, technology is used just to bridge the urban-rural health divide. I think technology is here to stay. That is my.
Fantastic. Yeah, thank you so much for that. It was tremendous learning for all of us here, and we look forward to listening over the next years. And I rightly said beside you, technology is the enabler for any profession. It should not be taking over the profession and also the knowledge, practice, and kindness. Thank you. You're absolutely correct. Thank you.
Thank you. Thank you, Dr. Basu. And thank you, Dr. Ganapathy. We are coming to a small coffee break. We're not going to have coffee break since we already had coffee in the room. We have Madam Sudha here, and she's going to speak to us, and she's going to talk about the National Integration Pledge, which is happening at the moment. Madam, over to you, Madam.
Thank you, sir. Sorry for barging in, but then so many things about the human touch and TLC being told. I think we'll have the administration of the National Integration Pledge of the day. Today being the 19th of November, every year, this is an annual event where the Government of India observes the day of national integration on the 19th of November. And at 11 o'clock on the 19th of November, 11 a.m., it is customary to have the pledge taken by every citizen of India. So let's have this here, after which I'll be too happy to join you and share my views on telemedicine.
Thank you, Madam.
This pledge is in Tamil as such. So those of you who are comfortable could repeat after me. So before I read out, can I request all to stand? Those of you who are comfortable with the language could repeat. If you are not so, doesn't matter. You could just join us in a silent observation. நாட்டின் சுதந்திரம் ஒருமைப்பாடு ஆகியவற்றை காக்கவும் வலுப்படுத்தவும் என்னை அர்ப்பணித்து செயல்படுவேன் என்று மனமாற உறுதி கூறுகிறேன். நான் ஒருபோதும் வன்முறையில் ஈடுபட மாட்டேன் என்றும் மதம், மொழி, வட்டார மற்றும் அரசியல் அல்லது பொருளாதார பேதங்களுக்கு அமைதியான முறையிலும் அரசியல் சட்டத்திற்கு உட்பட்டும் தீர்வு காண தொடர்ந்து பாடுபடுவேன் என்றும் நான் மேலும் உறுதி கூறுகிறேன். Nandri, thank you. I'll join you in the next few minutes.
Thank you. Thank you. Can I request Dr. Mohan Rajan to, say his views on telemedicine for the next 5 minutes, followed by Professor Natarajan. Yes, we will only sit and talk, no problem. Camera.
Yes. Good morning, friends. Actually, I would like to compliment Dr. Sunil Shah, Dr. Sendil, the entire team here for organizing this wonderful, I would say, webinar on the current topic of telemedicine, which is very important. as the president of the Tamil Nadu Ophthalmic Association, the 10-point agenda what I gave during my presidential address on September 11th, when I took over, and I mentioned that the TNMgrmu will work with the Tele-Ophthalmic Society of India, for which Dr. Natarajan is the president. And TNMgrmu, along with the Tele-Ophthalmic Society, will screen all the diabetics across Tamil Nadu. And we have already talked to the health minister, and we are trying to get a date from the chief minister sometime in December to launch this major project across Tamil Nadu, which will make all the diabetics screen all the diabetics so that we can pick up diabetic retinopathy much earlier than normal. Then another important thing is, as you all know, this tele-ophthalmology is something which is really picked up in Tamil Nadu. And there are major institutes like Shankar Nethralaya, my alma mater, the Aravind Eye Hospital, which has taken tele-ophthalmology to every level. Already, just like Professor Ganapathy, who took it long time back, these people have also, these institutions are also taking it to every nook and corner of Tamil Nadu. And I'm very glad to say that tele-ophthalmology is one of the gold standards in Tamil Nadu. And for ophthalmic education, as you know, this Tamil Nadu is the mecca of ophthalmic education. All the major institutes of ophthalmic education are in Tamil Nadu. Like Aravind, Shankar, so many other institutes are there, which means that all the postgraduates from the north, east, and west, they come here to do the post-graduation in ophthalmology, simply because the standard of ophthalmic care is much better in Tamil Nadu than any other any other state in India, which gives a reflection of the fact that we are not only technologically very good, but also in academic activities, the ophthalmology care is much better. And the main idea as the president of the TNMgrmu, I want to make quality eye care available, accessible, affordable to one and all, irrespective of caste, creed, and religion and socioeconomic status. And the only way we can do that is through telemedicine, and so that the telemedicine or the tele-ophthalmology can reach every corner of Tamil Nadu. That is the idea. And I'm very glad Senthil and Sunil Shah gave this opportunity for TNMgrmu to be associated with this wonderful conference. Thank you very much.
Thank you. Thanks, sir.
Yeah.
I request Dr. Natarajan, the president of the Tele-Ophthalmology Society of India, to give his views.
Thank you, sir. Thank you, Dr. I'm also part of telemedicine so that India because of my classmate Salomon passed the telemedicine so that the recently was country for several years, Dr. Sheila John, Dr. Mohan, president of TNMgrmu. So I have a dream plan as a president of India Ophthalmic Society. I introduced a program called Jobs using a program called Stop Blindness, that means screening through tele-ophthalmology, even diabetic blindness. I'm happy that the president of TNMgrmu is agreed to do an MOU. So my simple idea, which I'm going to put part of the program, is to use non-medical people, any pure or clerk or anybody who is interested, any villager, we can train them to use the fundus camera, either a mobile phone or any of the fundus camera for a 3-week course. And I've already got a certification approved by the Skill Development Department of India under the Skill Development Corporation, the Prime Minister program Delhi, where we will do the training, 3-week program, and we will be able to take photographs and either use the offline AIs or AI, and then they use it for screening of diabetic retinopathy. We have 77 million diabetics. About that, I think the idea that 8% do not know they have diabetes. So that means we have a lot of homework to do. It's involving ophthalmologists, optometrists, or any paramedical technical people. We are going to take people who are illiterate, or probably literate, but they are school passed, who can be given a job opportunity. And we are trying to do, along with the women empowerment in the West, I'm trying to talk to this company called Renew Energy. It is run by Smart Sinha, the 45,000 company, by Vaishali Sinha, who is the chef of some of the CSR of the company. They have 130 villages. I'm trying to impress them that we should start the pilot project in one of the villages in Maharashtra. So as a project, we have done an MOU with the Bombay Municipal Corporation. And for the last 3 years, we are doing the free fabric training using the mobile, so that it's part of the free of the program. And it's successful. And we have published that in JAMA. And the first of its kind ahead of Google on using an offline AI. Again, we have not developed it. It's developed by used by a company called Remedial Comparison. Another company for us, so I don't have any financial interest. So the whole idea is to healthcare reaches to the doorstep of every villager in India, and we have 6 lakh 40,000 villages in India. I'm impressed with our government where Prime Minister can address them in one go every year. And why not we do telemedicine or ophthalmology? And so in this way we can diagnose diabetes, highlight the, by taking a photograph, you'll know whether they have anything else related to hypertension. And when Google's Sugar Picture work is on using the blood muscle, we may be able to predict ischemic heart disease. And looking at the optic nerve, we'll be able to predict the Alzheimer and dementia, and also
Multiple.
glaucoma. So I think a lot of work is going on, but once we have made, the problem is the legality issue where you can use the photograph to identify a human being. So that's a problem which we have to address, and which will come under the telemedicine to make sure that nobody uses. That's where I think even Google was questioned by the federal government and because of the identity problem which can happen, which I think we have to be careful. That's why Dr. Kim is our president-elect of Teleophthalmic Society and also Asia Pacific Teleophthalmic Society, where he says we should not get involved in getting the images. We should only able to screen and let the image be with the people only. So that we have to evolve to make sure that every individual is, whether they have money or not, we be able to screen them. And after that, I think the government can, either the rural health mission, and we can also diagnose diabetes at the age of 30 itself, so that we can teach them diet, we can teach them exercise, and probably have a healthy and a fit India. Thank you.
Thank you so much, sir. Very valuable. Your views are very valuable, and I think it could be a game changer as we go forward.
I say just saying that audience are not.
Any questions from the audience?
So we can call them, no? Can you have somebody?
Ask you to call.
Let's try from the
Good morning, everyone. Those of you who are participating online, we would like to check that you're able to hear the conversations that are happening here. And we also want to know if you have any questions.
Good morning, ma'am. We were able to hear, but the audio is not clear there.
Yeah, okay. We'll see. We'll try to troubleshoot that.
We are not able to.
Are there any questions in the meantime?
We are not able to hear the conversations.
Oh, not able to hear the conversation.
Meanwhile, we would able to hear something is going on, but we couldn't.
We will be careful and make sure it takes, Can somebody make sure that the mic comes here when we are trying to? Yes.
Please make sure that audience also has a little part in asking questions, not in the meantime at all, because we also have some part in this meeting.
Yes, we know that, Dr. Raghav. Very important part.
Raghavan, can you start with the question?
Dr. Kim, are you online, sir?
Have you gone to the next section? I think,
The panel discussion. Dr. Kim, you are the next session. Are you online? Can you just stop? Check.
So,
Okay, so the beginning is start.
good morning, everybody. I am very thankful to Dr. M.G.R. Medical University and the two associations of the Ophthalmological Society. One is the Society of Ophthalmology India and another is the association. Those who have hosted this program, we are very extremely thankful to you, sir. Now, before I go to the main content of this program, the panel discussion, here I would like to share words about my own personal experience for decades. I'm really immensely happy to see this day coming to us. I have lived up to this age also because of the association for more than 2 decades. As early as 2002, I was introduced to telemedicine by Dr. Ganapati. He was the one who ignited the passion in me. And later on, Dr. Selva Kumar and other people actually supported me with a lot of logistic supports. Although I am hailing from the village side and the rural telemedicine I was involved with. And then thereafter, after developing a flair in telemedicine, I started my own telemedicine unit, that is rural telemedicine of e-clinics. Actually, in the year 2005, the term e-clinic was not familiar to the people, not even to the doctors also. And both the public and the doctors were equal at that time because it was not much talked about, not familiar to the people. At that time, the doctors even ridiculed, and then they used to see this telemedicine affairs in a town like my own, that is Vaniyambadi, where I hail from, the first of its kind in the Timbuktu district now. At that time, it was simply seen as just a mere talk with the patient over the telephone. Good here. Any interruption? You put the mic there. The mic was very sensitive. You not. Okay. I don't know where it started and where it left because it had some technical. Continue. Yeah, because of the technical problem, it was not audible to you people. I am extremely sorry on that. And now again to start my career, just I want to tell that as early in 2005, I got associated, and that time we have got lots of problems and challenges. We never had this 2G and 3G as comfortable as we are now. We used to manage the telemedicine part of it through my clinic, contacting the patients from the remote places beyond the town level with the help of two independent leased ISDN lines those days. And after that, only the 2G and 3G crept in. And now I'm really very happy to be associated here. And the topic is also rightly fitting now for the age, the untapped potential. Because that time there was no, the potentials were not being used at all. Doctors were ridiculing even this telemedicine part of it. They never knew what it is. They are not aware of the instruments available that time, the technological gadgets and all. We used to convince the doctor that one day or other it is the telemedicine. It is the telemedicine technology which is going to help the health services in a greater lot. And now the day it has come. Actually, because of the handheld devices and wearable devices we have been witnessing now, you are all very happy with the growing technology now. And there is no doubt that now, after this pandemic, actually the pandemic can be considered as a game changer in our field. It is the technological invention which has been associated with the now growing the services in the telehealth services in the medical part of it. Now we do with the consultation from the comforts of a room. I am also associated with, I don't want to name the business model for which I am working. I have so far, I have consulted more than 6,000 plus patients online. And now I am really very impressed that I have been following most of the etiquette of what Dr. Ganapati has told now. He has elaborated, and it has been a very immense help to me. And I felt that I should have been much earlier to the doctors who are involved in telemedicine. And now coming to the main part of it, now, sir, now I am being the moderator of this. The first person goes to the diabetologist, Dr. Lovelina Munawar here. May I see her, madam?
Next.
You. Now, the question here you can see now in treating diabetic mellitus type 2 patients, What percentage of your online consulted patients required to be brought to your own facility for further management? This question is mainly for you, mainly because you do consult the patients in an online setup. So if that be the case, should be very comfortable contacting the patient, both the new cases and the follow-up cases.
Yes.
In spite of all the comforts, what are the difficult areas wherein you need to see the patient in your room physically?
Yes, see, actually, not the difficult area, being patient by itself asks for the direct face-to-face consultation. They prefer more face-to-face consultation than the teleconsultation, even during the pandemic, because they were not able to explain the complaints to us properly. So that was the reason they opted to come direct consultation, though they have the teleconsultation facility during the pandemic. And apart from that, if you ask me as a diabetologist, to examine the pulsations, because to rule out the vascular diseases and the neuropathic, which can be missed out by just asking the symptoms, they might not be able to tell, and very few symptoms are there. We need to examine them in person to rule out the peripheral vascular disease, neuropathic. As Sir rightly said, we do have radio cameras to take the retinal pictures and other things, but still we wanted them to see in person to check the ophthalmic intraocular pressures and take a proper picture to rule out the minimal microaneurysms and other things. And for the inspection of the wound also, because though the resolution of the camera, everything is fine, but we are not able to cellulitis, or which is a very common complications in the diabetes, and in the skin lesions, which cannot be taken, which cannot be seen properly. Even the resolution of the camera is great, because we have to feel the temperature, because otherwise we might miss the cellulitis and other things by just seeing the pictures. These are the areas where we want to do. But I want to put another point, because we have done a study with 3,000 patients in our clinic, was approached also from 34,000 patients with us. Out of it, we have published a paper in July 2020. It's about the accessibility and the availability of teleconsultation for the patients during the pandemic period to see the control. Though the control has been, it shows a small improvement in the HbA1c, but one thing we have missed out is the patients who have utilized this telemedicine opportunity in diabetology still wanted to meet the doctor in person. The 80% of the people who have utilized the therapy during this pandemic still wanted to have the face-to-face consultation, because they might miss some complaints and other things.
Yes, I agree and infer that from your practice of teleconsultation to your diabetic patient, both new cases and follow-up cases, they were all very much willing to continue on online consultation, except for a small fraction of the percentage of the people who would like to see you in person. But have you ever evaluated that those who are willing to see you in person, is it because of the inadequacy in the online consultation, or mainly for the interventions which you want to?
Both, sir, both. I would say 50-50%, just because they were not able to explain complaints, and people have got a communication, the problems, and other people, maybe a daughter or a son can be a doctor who cannot accompany them during the consultation. So face-to-face consultation, they can accompany them, and they can ask much better questions than what the patients wanted to ask. And so these are the barriers what the patients find in very difficulty in teleconsultations. And number two, of course, the interventions, as I said earlier, so many complications and so many diagnoses by the end of the time. I'm not saying, what I'm saying is the teleconsultation cannot be replacement for the face-to-face consultation, but definitely it can provide a better,
I got you on that. Because so many people, including the doctors, that telemedicine is not a teleconsultation is definitely not a panacea. It is only a boon, and it is going to add on to all our health services, which would be of immense help to you, and we have seen it lively now during this pandemic.
One small comment I want to make. I don't know why we keep comparing traditional care of face-to-face consultation with telemedicine. They're not two different tools. It is just one enabler of your practice. Use it, discreetly where you require. Don't compare both different, as telemedicine standalone and face-to-face. That's where we go wrong. all the time people are comparing the two. They're not two different tools. They're just one tool. Please believe that. If you believe in that, then you know what you're doing is correct or not, and where to use telemedicine. It cannot be a standard ever.
Yeah, understand, sir. It is not for the mere comparison. It is mainly to upgrade ourselves and know the tools which are facing. Otherwise, we will be left the less. We don't know where we are, what our services are.
You're right,
Whether it is transferred to the public in a proper way or not.
But when you start comparing, then you
Not for comparison.
Then
It is to
it's not a different tool.
we need to know our shortages also, shortcomings also, so that we can upgrade ourselves.
So that is
So by comparing things only, we will come across so many handheld devices, wearing devices and all, which is going to help the public, and in a larger way, they are adopting it now. Thank you very much for your explanation, sir. I got you on that.
I think one important point is
Yes, sir.
the communication, sir.
Yes.
Somehow many of the patients will not be able to communicate properly. And I think that is one of the major barriers, I would say. That's what you are also mentioning.
Yes.
They will not be able to communicate, exactly tell what exactly is the problem.
In the time limit in the teleconsultation, they feel the time limit is very less on call, maybe a video or the audio consultation. That is what they prefer because
But
they
there
are not
not
able
be any
to
restriction on the time limit.
restrictions, but they are not able to express.
Express.
That's because of the mic phobia. Some people actually, those who are very new to this, they cannot talk over the microphone at all. And then generally they used to have the attendants by their side, and attendants and caretakers are there, they always help. Because I am involved in telehealth consultation for more than 25 years.
I understand, sir. Now,
So if that be the case, I have come across all these hurdles. I have seen them, I used to encourage them as they sit in front of the microphone, they do it. But as the time passes, after 2 to 3 minutes, they get offended and they just sit to themselves.
And I want to bring out a positive point in the teleconsultation. We have running a Chunampet rural model for the diabetes care since 2007. And, we've adopted along with the WHO and SRO a small village called Chunampet near the Pondicherry, and we run the teleconsultation, tele-diabetology van around Chunampet, and it has got a biothisometry. Doppler, we have a Remedio camera, we have a person who can operate the Remedio camera, we have a VSAT for the guy, and we have the teleconference equipment. And there we collect samples, and we were able to, because the healthcare was not able to provide a good diabetes specialty care in the rural areas, because 75% of the specialized doctor in the, this field of diabetes are there in the urban population.
Yes.
Yeah, so we are missing out the rural population. So from 2007, we have been cleaning the we are able to prevent so many complications. We are able to PMs. And this is a positive point, and we've been doing this from 2007, preventing so many complications.
Okay, thank you, madam. We all got you on that. One more question on diabetes itself, because there is an upscale management changes and that need to be considered and discussed for a longer duration when compared to ophthalmology. Please excuse me. Once on insulin, ever for insulin. This is the main problem from the society. We find it very, very hard to switch them to insulin whenever we do need to, because of the failure of the oral hypoglycemic agents and all. In your experience, how do you cope up this situation? How do you persuade them to go on to the insulin? The myth or the fact? We would like to listen from you.
It is a myth, sir. Once on insulin, definitely not ever for insulin, because insulin, if they are going to be a type 1 diabetic, LADA, because there is a problem with the LADA, because they'll be on control with the LADA is a latent autoimmune diabetes in the adult. That is type 1 diabetes, which occurs at a later date. The specific point with the LADA is they'll be under control with the oral hypoglycemic agent for some part of the life, right? And after that, they develop a GAD antibody, and that's when they become a type 1 diabetic. In that situation,
Thank you, madam.
Yeah.
Let us be concise on that because of the paucity of the time.
Whole issue depends upon the quality of audio and videos. If that is not good, people are not doing presentation, whatever you do. So you must make sure you've got a good video equipment, the audio standard. Like there are some standards. All of the same standards.
Sure, will be successful and people will be accepting more.
Okay. One session, this goes to Dr. Sendil, who is already a private player and a very renowned person in that, and his company name is WellCare Ophthalmological Services. It is something new in the era. Previously, we used to send the patient to the clinical lab and the X-ray lab only to draw the X-ray. Now, with the advent of this technology, and he has introduced to the telemedicine population his optometry, and he is doing online optic field retinoscopic facility to the patients and the doctors. Ultimately, it is going to reach to the doctor only. What is your opinion, sir? Are the doctors satisfied with the pictures? Are they comfortable? Are they want to do it on phone?
Thank you, sir. I wish you had shared the questions before.
I never said it should be known to the audience. I never said because they are all the stalwart, they are perfected in the field, and the question is also simple. But you can actually standardize your own services. There's nothing harm in it. What is there?
So basically, what we do is the diabetic patients have to be seen by an ophthalmologist at least once in a year. But most of the patients don't go to ophthalmologist. So just like teleradiology, we get the retinal images from the diabetologist, which are read by ophthalmologist, and the reports are given by the patient. So I understand that in your question, the doctors are physicians or diabetologists. Basically, they're very satisfied because previously they used to refer the patient to an ophthalmologist, but unfortunately, retinopathy doesn't have any symptoms. So patients don't go to ophthalmologist unless they develop. So if you wait for the symptom, by the time the retinopathy is already progressed. So
you got you on that.
So the diabetologist is happy because he is able to provide the test at his clinic itself, and they are very satisfied, and there is also a revenue model for them. So basically, that makes it work.
Okay, sir. Okay, very nice. We got you on that. We would like to take the person from the audience and the later part of it. That's next. She is the head ophthalmologist there. And which are those centers in India using artificial intelligence as a services, as a service at your institute? Because your institute is already conducting research work there with the artificial intelligence. You embrace that.
We are having a project with Google.
Sorry?
We are having a project, diabetic retinopathy project, where diabetic retinopathy is identified. And this is done by Google. Both Shankar Nethralaya and Arvind Hospital are doing it.
Yes.
And they've come up with findings where it can be. But still it is only done in the OPD where the consultants, we are not using it where we are doing camp work. We do teleophthalmology camps in the rural side. That side is being used yet.
Okay.
Only where I think Aditya Jodhai Hospital has done a lot of offline artificial intelligence.
How to see the future?
Future is going to be
It's going to be very good because I think
Let it be known to the audience.
yeah,
Thank you.
diabetic retinopathy screen throughout India, you can do with off. I think Aditya Jodhai designed and given very good results.
Yes. Obviously, the question is also projecting. How long you are in telepractice of speech, hearing, and language disabilities goes to Dr. Vidya Ram.
Thank you very much, Dr. Ikram. There's no, he said he'll mute it there, otherwise I can't hear. Can you mute that mic? Dr. Ikram, could you mute your mic there? Hello, can you? Yeah.
You haven't read it.
No, that has to be mute. Yeah. There's some other mic also that's on, I think. Okay, anyways. So I've been now doing teleppractice in speech, language and hearing since 2010, registered as a PhD student with Dr. Selvakumar. So this is now over a decade of telepractice in speech, language and hearing. And actually, the current experiences, we started off with more experimental methods to know whether telepractice as a service delivery will work or not as a research whether telepractice is good, is it better. So I think we've crossed that stage where we have to validate telepractice. But what we started off in 2010 was as a service delivery model. Is it working in terms of economics, cost to the provider as well as to the patient? Is it any different? And is there any value in that? And we did find clear-cut cost differences, and this was primarily all our interest was in rural telepractice. So therefore, I have some alignment to the thoughts that Dr. Lavlina shared as well. That it is very different for a rural beneficiary as compared to an urban beneficiary, and their acceptance and readiness is not always dependent on just the audio video quality or the overall interface that you're using. And currently, as of 2020, I'm involved in a Welcome Trust DBT Alliance project, which is a 2.5 crore project. And this is in Perambalur and Ariyalur district, and we're actually working with the government of Tamil Nadu in implementing telepractice for rehabilitation of children with disability along with the public sector system. So we're trying to integrate it in primary health centers as well as in NGOs as well as special education schools. And as a part of that, through this funding, in the last 1 year, what we have done is done a situation analysis, and this is where I just heard Dr. Ganapathy speak about how patients' needs have to be put in front, and I'm so glad we followed suit even before I heard him talk about this. Is we've done a complete situation analysis to know what do these rural patients need, what do these patients, parents of children with disability want with respect to services. Do they look at telepractice as an alternative option because there is no audiologist or speech pathologist in their environment? Do they think this is something we can use? Because as an audiologist sitting in Chennai, we always believe, many of my colleagues also believe that if smartphone is there all over rural place, there is very good data connectivity. Let's give home-based therapy with WhatsApp. But when we did these analysis, so we interviewed 56 fathers, we did about 56 mothers, we did focus group discussions, interviews with district disability welfare officers, with the state commissioner. So we took all stakeholders involved in service delivery and we did interviews with them and we analyzed in a pattern of what they wanted. And it clearly came out that these parents did not want home-based therapy. None of them had smartphones. So even if you suddenly give them one, there is no level of comfort to use these phones all of a sudden. They wanted their children to go somewhere. They didn't want to be involved in any more caregiving because they're so tired of taking care of these children with disability. They want some time off. So if you say, I'm giving teletherapy in your house, they're like, no, please give me some break. I don't want to take this up. So we felt there was a lot of reluctance among parents to actually take up telepractice. There is a lot of reluctance from audiologists to start telepractice because they feel their workload is going to increase. Unless the government looks into reallocation of their work profile, they don't want to take this up. They of course feel they need a lot of training to be able to do this. So this information now is extremely useful to us because we are not going to go to these communities and now say overnight, I'm giving you some new solution to you. This is great. The whole world is moving towards telepractice. So you all should come on board. We know we need to do a lot of community engagement. We need to introduce this in a very, very loving care manner, which as Dr. Ganapathy had pointed out, I think that is very, very important. A top-down approach is definitely not what is warranted when new interventions are introduced, including telepractice. So I think this is our learning from the current work.
You are not supposed to talk more, let us deliver the substance.
No, that's not what he's telling.
I just, when I ask a question with your permission. Welcome, sir. Yeah. Vidya, when you take fresh cases, you have reluctance. What about cases which you are follow up? Is there better acceptance?
Correct. So what helps is when you have a local community worker who's on board, who's a local champion. If they come through that champion, then there is more prolonged acceptance. But if you go there all of a sudden, they see you as an outsider, somebody who's come for your own ulterior motive. So local champions are the way to really start bridging this gap and engage with them.
Fantastic. Thank you.
Very nice. Yes, the important part of it, the closing remark, and I don't think that. Has he joined? But no, he has not responded.
Hello, sir. I'm very much here, sir, but
Yes.
I'm
sorry, sir, we are actually doubting whether you are joining or not. So
No problem, sir.
specific
No
question-
problem. No problem. We can continue.
Specific question was not related to you and it is not included here. But here publicly, we congratulate you on being elected as the Vice President of the national level. And now, now this is the last part of it. We don't have time. When it comes to remotely located village patients in particular, the touch inability hampers the diagnostic efficacy of the telehealth practitioner. This is often talked about and this is often complained in the earlier days when we were not having sophisticated online instruments, sophisticated videoscopic instruments available to diagnose the patient. Here, I take this question to myself because this is a age-long felt problem. This is considered as one of the gray areas in the telehealth practice. So we take up this. People, especially the doctors, used to ridicule us in the beginning days. You don't touch the patient, you don't follow the cardinal rules, palpation, percussion, and all those things which is taught in the medical colleges and all. How do you diagnose? Actually, as the age has grown, we all know that we are actually drifting away and away from those cardinal rules because of the availability of the modern technological innovative products now. We were not having the digital stethoscope now, we were not having the scan now, ultrasonic, we are not having MRCP center. Now, any physician who is consulting a patient finally wants to place his hands in confirmation, clinching the diagnosis that unless he sees the CT scan or the MRI scans or the lab reports and all after all. So, the diagnostic part of the problem those days was only with regards to the diagnosing the pleural effusion. Diseases like pleural effusion, pneumothorax, hydropneumothorax and all. It was not possible for the doctor to make the diagnosis on the spot. I mean, please note the word on the spot without the help of any investigations. Whereas a patient who is being inspected, examined in person physically, it is possible to say with 80 to 90% of the assurance that this patient is suffering from pleural effusion, pneumothorax, and hydropneumothorax, even without looking at the X-ray pictures and the CT scans and all. Now, with the advent of all these instruments available, the technological advancements, it is not a hurdle at all for the doctor to diagnose sitting at the remote end. That way I want to tell, because this was seen as the major greater gray area of telemedicine practices. Now to our good news is we are going to have the haptic technology also in the audience which is going to come, which would definitely allow the telemedicine practitioner to even touch the patient, feel the patient, and he can make the diagnosis by touching and feel the patient. And how far it has been advanced, I don't know. Probably Dr. Anybody will hit on that about the haptic technologies and all before I conclude. Thank you very much for all the participants.
Dr. Kim, sir. Kim.
Yeah.
Kim.
Yes, sir.
Sir, about your experience in the AI,
you
can touch on that.
Yeah, no, I wanted to answer two questions. One, regarding the acceptance by the doctors. One is you have to understand we are using this as a screening tool, not as a diagnostic tool. So today, this is making a huge impact. This diabetic screening, what Dr. Sendil is doing in bringing the patients, identifying the patients early on, much early on, what we call as opportunistic screening. So that's one benefit out of this. As far as the AI is concerned, we are all using it in real time now, screening the patients among the diabetic, from the diabetic clinics. And it is going to be the future, not only in diagnosing, but it is also making a lot of changes in predicting diabetic retinopathy for diabetic patients. So it is going to be there, become a major role in the coming years, sir. That's all. Those are the two things I wanted to add. Thank you.
Thank you, sir.
Thank you.
Thank you very much. So with the final remarks, Dr. Ganapathy? With the final remarks, I want to conclude that those were the days which we are faced with a lot of problems in the telehealth consultations because of the connectivity problem and for not having at least the 3G services to be available. So, but nowadays those hurdles have gone. We have still certain other areas which are to be looked out as we proceed, as we progress in our technological advancement. Definitely these things will be eliminated. Any more questions from the audience? You please go ahead.
Dr. Sunil sir, anything happening? We are already using robotic surgery now. The future is already here, to be honest. And haptics has been around for the last 10 to 15 years, believe me. And it has a lot of work has been done on haptics even in India. And in robotic surgery, the Devanshi robot which we're using, the next generation robot already has haptics available, where we're able to actually feel some of the organs. So this is a great kind of, we are moving forward very fast. Before we realize the future. That's how this technology is going, So, so it's sometimes very difficult to cope up with everything and to understand where to use it. So, this, one of the, challenges with telemedicine has been that, arguments has been that the doctor is not able to visit the patients at home. And with haptics and 5G and all the augmented reality which we have, what will happen? Doctor can actually visit the patient at home as an avatar. With haptics, you can actually touch the patient, and it's all done. So that argument also will fade away very soon. All this technology merging together. To have a big revolution, you need multiple small revolutions. And this is what is happening in technology today. There's multiple small revolutions are needed to a big revolution. Thank you.
So at what level the haptic technology is available now? Where all it is used?
It is used. Some of these robotic surgeries which we're doing.
Robotics.
In with the robot.
Used in robotics, yeah.
We are able to actually, to some extent, feel the organs. It's already starting to happen.
Already we have started talking about 6G now, sir. Even the 5G has not come, but we started talking on 6G.
Yeah.
So question from the audience on, we talk about AI-based ER analysis. What has been the accuracy rate in terms of diagnosis? AI-based ER.
I'm not a.
90 to 95%.
1995.
It's very, very accurate.
Very accurate.
Very accurate.
Are there any questions from the audience?
Will the AI be accepted by the ophthalmologists in future?
Absolutely, sir.
They will accept it.
AI is going to be the gold standard. I think it's going to integrate AI with teleophthalmology.
But the department don't work with the leaders concerned about it. But no,
In ophthalmology, it is.
Thank you very much.
Most diabetic patients.
Thank you very much, all of you. I hand over the
There's
proceedings.
no, it helps.
Thank you.
Ophthalmologist is not the diabetic.
Finding it what Dr. President is doing is also very good, sir.
Yeah,
The accuracy is.
Yeah, you have questions from the audience?
Yeah, they
Go ahead.
If it's that, what are the challenges to scale it?
scaling the AI further.
Dr. Mohan, would you like to?
How are you going to scale it further? The AI is being satisfied. How are you going to scale it up?
You can, because they can't hear on this.
Can you come just? This is from the chat. We have some questions from the chat box.
Yes, sir. I think AI is going to become the gold standard as far as ophthalmology is concerned. I can talk as an ophthalmologist and how the DR screening and how it's an indicator for even cardiovascular disease. Google has Sundar Pichai said that, and how we can scale it up is use the technology and the offline AA, which Dr. Natarajan is doing in Ahitha and Mumbai, is also very good. Where we use Remedial cameras, the offline AA is really important so that we don't require an internet connection at all. So the AI is going to become, I think, the gold standard as far as ophthalmology is concerned in the diagnosis of diabetic retinopathy or any other eye disease.
Sir, can I answer that?
Yes, sir.
I just want to, for scaling up, we don't have to do anything. The instrument manufacturers will automatically integrate it into the system, and that's going to be the future. So whether we like it or not, it will be there. So
yeah,
thank you.
Yes, Dr. Kim. Yes, thank you very much.
Dr. Kim, can I ask you a question? Ganapati here. See, there
Yes, sir. Your audio is not very clear, sir.
Come this side, sir.
There are going to be major problems regarding medical legal issues and regulatory issues. Already cases have been filed in the United States where an ophthalmologist used AI. Something went wrong. Now, who takes the liability? Is it the software developer, the programmer, the company? You know, these are huge questions. One, two, is it mandatory for me to use AI? If AI becomes the gold standard, will I be penalized for not using AI and for using NI, natural intelligence? So these are all things which are going to come, and I anticipate a lot of problems. I mean, it's not so simple. It's not a question of algorithms. See, algorithms cannot be applied just like that to human care. How many patients I know, patients still depend on the human brain to take a decision. If I tell my patient, look, AI suggests that you have this, and I want to take preventive measures, I'm not at all sure that a patient has got total reliance on an algorithm.
Absolutely, sir. Absolutely.
I'm not sure about the other specialties. We don't know because we have got good groundwork as far as AI and diabetic retinopathy is concerned. The specificity and the reliability is close to about 90 to 95%.
Yes, sir. Yeah, absolutely. What you said is true. There's a lot of gray area in that. Only now, as you know, we have had these telemedicine guidelines come into practice. So it's going to be time before we have AI, regulations for AI in healthcare. Till then, it's going to remain as a gray area, sir. I agree with you.
Thank you, sir. Yes, sir. Thank you. Thank you very much.
Yes, sorry. The last 18 months, one of the very exciting things which we were able to do was training of doctors to Telemedicine Society of India. I'm very happy to say that Tamil Nadu chapter played a very big role in that. Sensitized more than 25,000 doctors. Sorry. And we were doing face-to-face training for doctors initially through webinar mode. It was very labor intensive in the sense that we had to be actually physically present. We did 57 such training programs in April and September last year. And then it was felt that it's too labor intensive because every time 3 or 4 faculty would be in the room for good 3 to 4 hours or 2 or 3 times a week, and it was not possible. So we had trained by the 6,000 doctors, including 100 from the army. Most of the training was done free. Towards the end, we did get some sponsors and some money. And after that, we decided to go online. So we developed this program on Moodle on a self-learning management system. And we have developed 2 courses. One is on foundation course for telemedicine practice guidelines, which takes 6 to 8 hours to complete. There are 4 modules. It has an introductory module, the telemedicine guidelines itself in that. And then we have ethical and legal aspects of telemedicine. We have how to implement telemedicine in your practice. And then there's an optional reading module. So before they start, there's an assessment which happens, pre-course assessment. And towards the end, a post-course assessment happens. And then they get a certificate from Telemedicine Society of India. So we started with the foundation course. We launched it this year in the month of May. It took us a long time to develop the course curriculum. There are a lot of video lectures which are interactive. I want to show you, but the site is not opening. I don't know if it's the browser issue or what. I wanted to show you live, but at some stage I would like to show you. But I want people to know that they can take actually. He teaches you about the regulations, he teaches you about the etiquettes, he teaches you about how to conduct a telemedicine consultation. So a lot of work has already been done, and that's why I was requesting that we should probably get an accreditation. The Maharashtra Medical Council has already accredited a course for CME points. And we are hoping that, we can get more information from Tamil Nadu Medical Council as well. Let me see if I can open the site. And then the reason I want to show people is that, I said earlier, they could probably want to take the course. They can now. They do have an option. Yeah, within a year. We give them a year to complete the course, not 3 years. The government of India has said. Yeah, the government of India has said that an online course will be available, which all medical practitioners will have to take, and this will be part of the licensing, process. But at the moment, nothing has happened. In fact, we are talking to the NMC whether they can take this course and make it the course which is available to all the practitioners, because it's going to take time. Any course you develop needs to be thought about, needs to be structured properly, needs to be delivered, the content needs to be done. So we have done all that. Hard work has already been done. So we're actually approaching the NMC to see if we can, take it. But let me see if I can open the TSI website itself. There seems to be some issue with, I think, internet in the university. I don't know. Registers. If you want to, access the course, let's go to psi.org.in site and go to the courses. Everything is available. There's a short video of the course available. It shows you what the course is about. Let me see if I can at least, show you some of the. I might have a video back then. This is what sometimes technology does. You never know when it's going to hit you when you do a presentation. Anyway, I will try and show you the video later because there is no, access to the internet, because I thought there would be access in the university, but somehow looks like we have our telemedicine society site also is not open. I can't really say unless we have but I don't know why it's not coming up. The meantime, let us.
So you want me to show that video, sir? Telemedicine video?
I will show you, but just give me 2 minutes. Well, we are so dependent on internet at the moment. This is what. This one. But I'm free to answer the questions. The diabetes course has been Dr. Mohan, who is also a member. He was supposed to be here, but unfortunately he's traveling, and so he's not able to join us. So he's helped us to develop the diabetes course, again 4 to 6 hours. We already have a pediatrics and a course also with the Ayush practitioners. There is a guidelines for Ayush practitioners as well for the Government of India. So we are speaking to them also to develop a course for them. The pediatrics and the Ayush course also should be there soon available. How many of Tamil Nadu, I think we have so far, we may have, I don't have the exact number, but overall sensitization we've done to about 4,000 doctors. Tamil Nadu. We did one course with a doctor in Erode. We did one course with a doctor in Trichy. Of course, Chennai, we're doing it very regularly. So I think, Tamil Nadu chapter has played a key role, which is not well known to a lot of people. And I wanted to show you all how it is being done today. But if I can opportunity later on, I think we'll show you. But I think
Dr. Shroff, you want me to share the video from this end? That 1 minute.
Yes, can do that, it will be wonderful.
Yeah, you have to stop sharing there, I think.
Yeah, I'll stop sharing. The video is available on the website.
Yeah, from the website.
Yeah, thank you, sir. So kind. Show the website of the E.
Can you see it?
Yeah, you're not sharing it.
Is this the video you wanted, right?
Exactly. Thank you, sir. You really come to the rescue. And can you also show that the various courses to be developed after this?
Okay.
This is the sound. There is sound also.
definitely. Dr. Kim, we are not getting that audio. Yes. I think you may have. Without video, it's like eating is.
Wants the link to the course.
Yes, tsi.org.in/learn, LEARN.
Streets and
Only for humans.
What do you have the expertise at?
These are all the participants.
Dr. K. That's the.
Dr. Kim, we could not hear the audio.
Oh, I'm
The way you
stopped.
can enable.
Sorry. I stopped sharing, that's why I think. You couldn't hear the audio from the beginning?
You couldn't hear the audio, sir.
From the US.
Can I show you the video here? I can show you from here. I have it here in my.
Okay.
This, if you can hear from here. We are charging now online course. We are charging started with 650. We had very good participation, so PSI decided to double it to 1200. Yes. That's GST.
First page, they did not charge anything, it was free of cost.
But I took mine even free of cost.
People did not.
Okay. No, they accepted it, but accountability was not there.
It's always been a system. Gopal, I have the possible to get a list of engineering colleges affiliated to our university. Certainly possible. It's available online. It's online. Short file, you can customize email merge and all. Send a mail to all the people.
I think we'll do that, sir. I think we'll do that, sir.
Will you help us, sir? What's something we have a simple for affiliated institute? One job. See, that's the colleges is far from make a tremendous impact. More of an economic, sir, one I think we need to continue.
Yes. I know, this is good audience. We will continue, and if we get an opportunity, I'll borrow 5 minutes from the whole program. And I'll try to show you a video and the course is online. So we'll proceed. I don't know what the next session is. Send it. Are you here? Yeah, we'll do that. Masood, you are here? As the chair of the next section. We are doing well for the time though. How to set up the next
2 generation telemetry fathers. That's in India as well.
So we're going to put the next session and we are half an hour ahead of the time. Great. And so this session is how to practice, how to set up. To handle the consent, preparation for teleconsultation, platforms for teleconsultation. Do it yourself versus video. Security. The chair of the session is going to be Dr. Kim. Speaker is going to be Dr. Masood. Yes? There you go, Masood. You've got a lot of things on your agenda. Here. Come here. You will do it from your laptop? Connected to the main? No. I'll take a hand here. I would like to add a few words before he comes. Masood is my son, and he has been growing with telemedicine affairs side by side along with me for years together, for about 15 to 20 years. And he is going to tell you how to set up a telemedicine clinic
the infrastructures are not needed, those needed for that. I'm a Masood. My apologies for not giving a good introduction to Masood. Masood is actually a doctor of medicine, interested in technology, doing a lot of work on AI and chatbot. So he ran a hackathon for us very successfully in telemedicine 2020. Very young, promising future of telemedicine in Tamil Nadu, is not India. There you go.
You should not be introduced as yourself. He's saying you are the father. That's how it works.
So we are going to be transferring some of the files. You have a US, where it has participants. You will have to come to us. Unfortunately, that's very challenging.
Patient who is having ailment, first limit everything only to the ailment he thinks is an ailment, he or she thinks is an ailment. Others are all hidden. It's not communication skills.
The audio is very poor.
Is advanced technology an answer for that? But a medical will get more.
Can you come here?
Sorry, I'm sorry, my apologies.
Can you hear now, Dr. Kim?
Yes, it's better now. Definitely.
I'm Gopal. I teach computer science in Anna University. A patient whose focus is primarily on fever would talk everything about fever and everything else is hidden. We believe that the medico will get whatever is hidden. Is telemedicine and advanced technology going to help the medico in getting what is not said?
I don't think so. Getting the telemedicine guidelines itself says that you need to go into the history of the patient, look to the previous notes of the patient, do as much evaluation as possible before you actually decide to do a teleconsultation. And then it is your judgment. So that patient is fit for teleconsultation. If a patient has fever for 2 or 3 days, you may be able to give something. But if the patient has fever for a month or two, you definitely want to see that patient. So fever is can be of different grade. A short fever, yes, you give paracetamol, observe for a few days, and come back. A fever for long stay.
Live surgery, free live surgery. It's first time yeah. If you want 3D live surgery. Yeah, government of India.
This is the important topic to know what is what in telemedicine. Now you are going to hear to Dr. Masood.
Good afternoon, everybody. If I have permission from everybody, Mr. Kim, I can start with the
Yes, please.
Thank you so much. I would like to start from last slide, actually, which I recently added. It was like 10 minutes before, when Dr. Ganapati and Dr. Kishore was talking. Look at this. This is a picture of 2005 and 2006 September, when I did my first telemedicine course with Anna University affiliation with Apollo Hospital.
2005.
It was a big news. It came in newspapers. Anand was there. The Ganapati you can see there. I'm standing somewhere behind. This is if we talk about the history of telemedicine, probably I'm the first person to do this course from Anna University. And today's generation is what we're talking about. We should be doing more courses like these. So I wanted to start a presentation with showing that, there is a history behind it. And the future should be there for this. Thank you. I'll give you this copy. Don't worry. I'll come to my discussion. So, see, it has been spoken about telemedicine, and most of the people also know more about telemedicine. It's nothing new. The fact that we are doing this entire conference in a teleconference method, and people are listening, so many people are listening to other side, it means that most of us already know how to basic set up teleconferencing or a particular forum. How do we talk about it? Things like that. What I could, I'm open, audible. Somebody can confirm if I'm not audible from your end. So what I would like to touch upon is a little bit of psychology. What happens in a telemedicine? What are the days? What to do? What not to do? What are the regulations are available? So already spoken. I will touch a little bit on regulation. Kind of applications are available these days. There are too many applications available these days. Not good. How to select which application? What application is right and what is not right? Little bit about the right application. How do you go select your application? I would like to go on that and a little bit on the payment gateways. Payment gateway discussion these days. Not a regular video call. This is what I will start off with because we are doing regular calls every day. But when I talk about a telemedicine, it is not just a regular, not just a video call. There are video calls happening in a company, there are video calls happening now, they're happening in a family birthday. But this is not a regular video call. People expect us to come and stand there, be there available for 24/7. If not 24/7, they expect us to be there for at least 8 hours a day or whatever time we have, be there available for them. Professionalism has been discussed already by Dr. Ganapathy. The fact that we have to discuss about professionalism itself is the reason that it is a sensitive topic. Because the patients on the other side do expect us to be more professional, sit with the proper suit attire and the background and everything, not just a regular video call where we just sit in our own whatever costumes we're currently sitting over there. They expect us to be better scheduled. We are supposed to be well informed. They don't expect any margin for error when it comes to paid telemedicine concern. They have to be very particular about this. Okay. Regulations are very important these days. Nothing is free. Nothing is easy to be taken forward. You have to be informed about the regulation. I'll touch about regulation in detail later. And culture and decision making. This is becoming a bigger issue in day-to-day. What generally happens is I would go to a medical college in Salem or Coimbatore or Tirunelveli. I know the people locally there. The people also know locally about me. I know the culture there. I know everybody there. But in telemedicine, the geography is becoming like an old history. We don't know. You might have to be doing telemedicine to somewhere in Nigeria, Lagos, somewhere in Iran, somewhere in US. So we actually don't know what is happening at the other end. What is the culture, thing like that. So be informed about a culture situation. All these things put together, it is just not a video call. So it is much more than it. We have to be literate. Setting up a telemedicine. You guys are smart enough today. We don't want to touch too much about how to set up a telemedicine. A video call, a smartphone from that end helps you with a particular thing. So what I would like to tell a little bit about here is, I would divide this topic into man material, how to manage and communicate. What happens man material? So, what kind of man you want? Basic front office lady should be there, schedule your appointments and taking forward. And you will have your and you need a basic nurse and even take your vitals and inputs and take it forward. You need a couple of people who have been trained in this and taking it forward. So if we talk about front office scheduler and nurse and everything, again this goes back to doing a telemedicine course and coming back and sitting in front office for the particular telemedicine becomes a very sensitive issue over there. When it comes to a material, to understand what material is required, we have to understand telemedicine per se. So telemedicine is basically a two-end phenomenon. One is the doctor's end and one is the patient's end. What are the requirements of doctor's end? What are the requirements of the patient's end? A doctor's end is very simple. Doctor needs an audio video or it can just be an iPad or a phone is enough for a doctor from one end. The other end is what is more important because it has a lot of hardware. Now it can be as simple as an audio video there on the other end, or it needs to have a digital BP, digital thermoscope, a digital ECG. So, see, a lot of this hardware, when we talk about it, it costs. moment we think about cost, then we go into an ROI, go into a lot of confusion. So we don't have to get into so detailed. Somebody starting up a new telemedicine center, a nurse on the other side can take a basic vitals and what's available and take it forward. If somebody feels that integration a particular thing is required, yes, they can go in for this thing. So it starts with simple webcam, it goes up to a thermometer, ECG, retinoscope, or it can even go up till telemedicine van, a mobile telemedicine unit to that level, patient available. How do you manage? So the moment we talk about manage, it is like managing a hospital. So when you manage a hospital at your level, managing a telemedicine is also a management in that level. How you manage, you have to have registers, you need to have records, you need to have follow-up, pharmacies, the vitals, diagnosis, the references. We need to include all these things. Sometimes it is very simple to go with an application. A better application makes these kind of things are much easier. The moment we say application here, then what kind of application, how the application. So I have a separate slide on application. I'll go to an application, how to choose an application about it. The last part is communication part. Though it's a world that India is the cheapest form of communication everywhere. Even though everything is there, we still had some issues. And my voice probably not reaching a lot of people in other end. So communication is there. We recommend basically yes line. And we also recommend a backup line because during floods and everything, this is the place where telemedicine is more required, and there's big chances that the communication goes down. So having a backup from two different companies, you have taken Airtel, already have a Jio, or the other end, so having two backup lines is always better. Very basics about telemedicine. I'm not going in detail. People are smart. People are sitting here, already sitting in a video conferencing call, so don't want to end up adding much. But here, these are the factors which I want to specify and make sure that I think enough sensitivity towards all you people to think when a telemedicine is happening, what are the real factors we have to think for? Data collection. The moment we talk about seeing a patient, there's something called a data collection. A data collection is organically produced when you do see a patient. But what are we doing with the data? Are we using the data? Are we not using data? Are we collecting it? Is it important to collect the data? Where you can see a lot of applications are available online, offline, and it's available. What are they doing? They're giving you free applications just for that. Use the particular application, and they come down and they use your data for their own purposes. So data is the key. Data is the new. That's what Reliance says. Reliance says the new oil on the data. So how you are using your data, how safe you're keeping it, that's more important. And if you're doing it your own application, that's the way you are able to do it. You're using a third-party application, then make sure that the data privacy what they're using is also the standard ones. Standard what we have in Section 7. All you need to do here is you need a front office sitting there. Take basic information. What is the basic information about it? Collect all information and everything because legally also they'll help you protect yourself. Second part is regulations. So it's not a video call. You have a lot of regulations coming in, and you have to be adhering to a lot of issues in the future. Right from the beginning, if you have enough information being taken from the patients, then you have it better. So you basically, the first and primary thing you need from a patient is that consent. When I say a consent, the telemedicine consent is different. I will give a format like what the telemedicine consent looks like. Consent, the most important thing what you see is it is not used for emergency purposes. So that is the more important thing. And if you're using a third-party app, so you have to say that you're okay to share your data with us, and the shared data is going to an app. Along with the consent, it's more important to even take an address proof. So KYC is become a big thing everywhere. So you have to have, even if you want to buy a FASTag, you need a KYC details. Yes, address proof is more important. You never know, sitting people from other country, they just change the name, take some prescription out of you and use the prescription against them. So you better to have address taken from them. Is it consent required for every time you do a teleconsultation? No. The first section you need a consent. Followed by every consultation you do, you need a disclaimer in every prescription you give. See, disclaimers are very important these days because medicine was banned by our own country for a long time because of the reason that if you give a digital paper, people can misuse the particular data. They can change the data. They can add what they want. They want to add codex. Whatever is there, whatever is not there, it has to be, they can be adding it up. So, good disclaimer in every prescription will definitely protect you. And a disclaimer also should go with a correct timestamp. I was given this, I gave this particular prescription on this date and this time, and this was the thing. If somebody goes against it, we can go and prove that my original copy is this, and this was the timestamp being used on this particular time, and I had not written that particular. This is how you can yourself with the disclaimer putting it into that. Digital signature, I would recommend to people, how for digital signature, you would have seen in my initial slide, I had one digital signature of my own. It's very important to have a digital signature by yourself. The patient other end, some confidence. He needs to understand that, what he is holding in his hand has some value. So these things, when you take a concern and you take a exclamation and then you have a digital signature put to it, the value of your prescription goes up. The people will vouch you more, they'll come back to you more. Just don't treat it like, somebody is asking me, some relative is calling me and asking, treat it like a more professionalism, have a digital signature, have a very neat and most important thing in regulation is MOU. MOU with this third-party apps. A lot of third-party apps are available. We have to read MOUs with them. We just sign off and we just continue with them. What happens to the data? What happens to the privacy of the patient if any issue happening out there? Everything has to be there to be read, modified. They would like to prepare an MOU to keep themselves safer. So they will put you in trouble if anything happens for tomorrow. Make sure that when you have both the way, it has been balanced from all the sides, on the patient's perspective, on your perspective, and everybody's perspective. Again, I'm coming back to the data important, data management. What is the standard recommendation is, wherever you keep, whether you keep it in your own, whether you keep it in somebody else, have two forms of backup. One is your digital backup and your manual backup. What is the manual backup? A digital backup is very simple. You use one more different to keep all the data over there. That's how you give two different communication lines. You use two different backups. A manual backup is something you do a physical backup on a hard disk or in a pen drive, put in every 6 months and save the data from there. Manual backup is generally recommended for two different people, different industries. One is financial industry, one is health industry. Financial industry because money is important, but health. Wealth is more important than health. So please have all the data set up over there. Local laws. I just mentioned some time back that you've been treating a patient who is somewhere in Europe or somewhere wherever it is. What does the local law says there? The local law of that particular country is important. I can go in detail about it. One example. What is GDPR? GDPR is General Data Protection Act. GDPR. That is basically coming from the European countries. GDPR is very strict. Consent form of GDPR is so elaborate. Consent form of GDPR for minor and major is entirely different. So if you're treating a patient with a minor, you need to have a different consent form than the consent form of this thing. So everywhere, when you talk about geography, once upon a time we don't worry about all these things. I've never met an Australian guy, I've never met an US guy, UK guy. But now geography is shrinking. You need to know those laws, their laws, and their understanding of what's happening there, what is going on in that particular end. I'll give you one example. What happened in GDPR? Google had to pay a $4 million fine in Portugal. Portugal hospital had put a fine on a particular on the Google, and Google had to pay $4 million. Very simple fact that it was not able to maintain its data in some other room, and they were not able to retrieve the data or some small issue, a very small issue, but GDPR took it very seriously. When a hospital is complaining, it becomes a big issue. One example to tell you how local laws are important. Don't just understand that every patient is a patient for you. Patient coming from a different land will have different laws. You have to understand that particular law. Read about them. If you are doing it for Nigeria, if you're doing it for any African requirement, based on that you can go. A simple format of a consent form. I wanted to put it here to have you to have a small. There's got only 7 headings, not much detailed headings. The more important here is again you can see data coming in point 6. And you can also see limitations put over there. I'm aware that telemedicine is not equal to face-to-face consultation and not by accuracy, not accuracy maybe low. It's more important. And you can also put non-emergency teleconsultation. So non-emergency word is more important over there. So you can see now so many applications are available. Any number of applications available online. So which application to go for? Which application is good? I cannot be recommending every application here. What is right or wrong? I can give you information about how to choose, or rather to first to dissect the entire application. What does an application have? To have your understanding. Then you can see whether what application is good for you or what is good for somebody else. I would dissect them in 4 different parts. One is basic appointment. A basic registration and basic appointment is very common. Anybody can use it. Second, you will need to have a clinical workup. A clinical workup is, you put your vitals, you put your diagnostics, you put your references, you put all of it from a clinical point of view. First, you want a registration appointment point of view. Then you get something like point of view. You can understand this prescription is some topic every time we talk about telemedicine. The prescription is entirely different from clinical workup, entirely different from a registration and appointment. And last part is your billing and payment. Now, applications, I tell you one bad thing happened. Not people were not happy when it comes to one particular application. I don't want to name the company here. So what was happening is there was a free registration appointment being given by the respective company. We all were using it very well. We all were very happy using it. Then later what happened, the same company had its own online pharmacy and its own online diagnostic, free sample collection from your home. So he was able to read your prescription and he was able to send them separate discount saying that I have given you 20% discount for the specific drug which you have done. You would have your own setup with your own pharmacy and everything, and somebody just giving the data left and right. I don't want to name the company here, but you need to understand. So all these companies will give you end-to-end product. What I will recommend here is either use all of them as you want to do it by yourself or mix and match. Use registration from one application, clinical workup from different applications, have your own prescription sent in an email as you would prefer to. You can model it by yourself, or you can go with all. Either you divide yourself or use different platforms or mix up with one. The choice is up to you. But be aware is there what is not there. Being aware is more important than getting cheated by somebody else. Payment gateways. This is one of the most interesting topics. People get confused. How to even ask for the money. Third particular apps, third party apps, what you currently have, they themselves have a third party gate. You don't have to worry about it. They do it for yourself. They do it them for you. And of course, they have their own revenue being shared by them. So you have to pay someone. That is one option available. WhatsApp payment. Please, whatever you do, don't use WhatsApp payment. WhatsApp, Insta, Facebook put together, already know enough about you. They know enough about what you drink, where are you, how you eat, everything about. All they don't know currently about you is your financial spend. They're very curious to know more about your financial spend. You have other good payment methods, so WhatsApp is not the right choice when it comes to payment method. So any social media platform. Social media platform, use it like a social media alone. Restrict it if you want to. If you want to use it, you hang up to it. Good enough. But please don't use payment from your social media handles. You definitely have your GPays and PhonePays available these days. But the problem with GPays and PhonePays is somebody has already paid you the money, but you might not be able to reconcile them. For example, you name was Geeta, consultation completed with Geeta, and elder sister Geeta sent you the money. Now we don't know Geeta's money is Geeta's money, who is what. Reconciliations become an issue. If you can manage by your front office, good enough, but there's one option simply available. There's one more option here called payment integrators, like you have this Razopay, PayPal, and Paytm. Interesting thing about this kind of Razopay, they have become very advanced these days. So what is generally happening there is if I have to open a Razopay account, I have to have a current account, I need to give all my company details and everything. Now with just your PAN card, you can open Razopay account. And what happens in Razopay account? Either you can integrate your own payment in your app, that is part one, it's easy to do, or create a separate link on your name. And if you ask a patient to send me the payment, all you need to do is send a particular simple link. He clicks the link, your link opens, your logo is there, your name is there. You can ask the patient, enter their detail like phone number, email ID, and in their own name. You can easily integrate and see who's paid the payment and how much. And you can also fix the amount. For example, your mini consultation is 1,000 rupees. You can cost not less, not more than 1,000 rupees. So exactly you know how much payment has been. But one thing with payment integrators is they charge 1.9% of the service charge. 1.9% is close to like 3% service charge. I will still recommend because it brings professionalism. It brings because your logo is dedicated page, lasso pay will not be there. So it's a more professional way of using. So I would recommend integrated payment. Last, much cheaper, much better situation. Create your own UPIs. UPI link. So instead of giving them a phone number, instead of doing that, create your own UPI. A simple UPI is like my hospital name at YBL, or Masood at YBL, Ganapati at YBL. So you can custom made UPI. Go to a phone pay, inside the phone pay, create a custom UPI. When you send an UPI, when the patient says that he's paying that particular UPI, and UPI has your name on it, it gives you a much better confidence for the patient to pay the money there. Payment available option, I would recommend last, which is like create your own UPI first. If not, you can better go for a payment integrator thing like that. Payment integrator will support payment gateway. I've come to my last slide, and it's also a summary slide. It is like, what is better? Self-setup is better or a third-party platform is better? This is one major question. How do we go about? So, just mention here the advantages and disadvantages of having a self-setup or a third-party setup. You guys smart enough how you can take it forward into this. These are some of the points which helps you understand segregated information. Self-setup doesn't have too much of segregated. You have bits and pieces by yourself. Front office will have some information, nurse will have some information. So the segregated information is not. Similarly, when you use a third-party app, you will have seamless information. They put everything in one particular platform in such a easy way. Third-party app is better when it comes to seeing the information. No assistance required when you have to do a self-setup. Because you need to take the information from the patient, you need to have assistance required in front of. But in a third-party app, the app is being created in such a beautiful way that you don't need an assistant, can do by itself. It's the advantage of third-party app. Data security is good in a self-setup app because you know where to keep your data, how to keep your data. I just spoke about digital backups and other kind of backups. So you can do a very, very good data security by yourself. But what happens in third party, data security is not so good. It's just not that the guy who is sitting, the company who's might be taking up your data. Any employee who's working in that particular company, he can be a general manager, it can be as well as executive. He has all information because he can go into front and back end. He can even take up your data. So when the moment you say the data is there in third party, it's open. It's not anybody else. It's everybody else. Piracy, yes, piracy is a bigger issue because in self-setup, you have a very good control on your piracy. In third party, you might have seen chief minister of the state or whatever, you have seen some kind of celebrities. Every information goes to the third party app and it can be open for available. Generate your own patient lead. In a self-setup, you have to take care of your patient and you will not be getting any extra patient. You have to generate your own leads and the leads. But in third-party application, they help you get good leads. They go to the market, they project you everywhere, and they get you good patient leads. For a new startup new doctor who's come out and who wants to do a telemedicine, companies, they will help you get good patients who are sitting at home. You don't have to worry about it. But of course, they charge their own share into it. That's why I said, in the self-setup, there is no sharing of the revenue. Everything belongs to you. But third party, there is a sharing of the revenue coming out. Constant engagement. We don't worry so much about engagement. One patient comes and he goes, the next time he comes, we take care of him. But when it comes to a third-party platform, there's constant engagement. They keep giving something dengue is coming up. They will say what dengue is or dengue is not. So they give constant information. I've done some. More reliable. So self-setup is much more reliable, more easier. It's there in your hand. And third-party platform, which is not at all reliable, you have to be making sure that. There's something called rating these days. Uber driver and rated, including the self-setup app, there is no ratings available. You are on your own. But you go to a third-party platform, he puts you into the market and the market rates you. Then you have to watch out for your own rating. This is the basic information available for a third-party app and a self-setup app. Hope this information was useful for you to decide whether to go for a self-setup app or a third-party app or a mix of, some one platform from here, one platform from there, use the information. However you want to use it and take it forward. I'm done. I'm open for questions.
Thank you, Dr. Masood. That was an excellent compilation of how to set up a telemedicine in practice. I think your experience really spoke out on the components that you presented.
Thank you, sir.
I leave it for the questions, if there are any questions to be taken up.
Just one comment. I thought it was a very informative, very well presented, excellent. Congratulations.
I thought something is coming from there. Thank you, sir.
One comment, I thought you are more like an auditor.
Difficult to believe you were an MBBS once upon a time.
You are more auditing.
Thank you, sir.
There is a long question from.
Bhagwan, please ask.
Yeah, maybe part by part.
Looks like there are some questions from the participants. I see some long comments, but Dr. Harita can just unmute and ask the question. There are lots of comments, but whatever question you have for the group, you can.
Hello, ma'am. A very good afternoon. Am I audible? Hello.
Yes, Ms. Rita, you are audible. You can go ahead.
Okay, thank you so much, sir.
Okay.
Firstly, I would like to start saying honored to be here and to know about the advances in technology and medicine field. And being from electronics, I would like to draw the attention of all today to the fact that it's the need of the hour that we have to increase the reach of all these telemedicine and teletechnology areas where the health problems are most prominent. So I feel that we need to address this issue. The expertise and guidance of solvers like everyone present here today. And I would like to know that how can we bring together these professionals from the field of engineering and medicine who can come together, poor and the needy people, and bridge the gap between the knowledge and technology. This is an opportunity for people, sir.
Lakh complete, not 2 lakhs, 60,000 complete immediately. That's the first statement wrong. Sit here. You need to go China. And they all who are asking questions also provide their name and email address. Can we record? If you cannot able to answer your questions and send it over by email,
Also have a suggestion.
Yeah.
Dr. Kim, just a suggestion, those who are asking very good questions, we would like them also to provide us the answers. If they can interact with the secretary and the president, we will help them and hold them. But they are the ideal people to implement all the questions they're asking. We will help them.
More of a comment. Any other questions, Vidya? Dr. Rak? Or shall we go on to?
Any other questions from the audience, the virtual participants?
So, otherwise we proceed with the Prof. Natarajan's position. Come here.
Good start. Oh, I am.
Give presentation. Here you go. Sure, I will give some.
So it's a privilege to introduce Professor. So he is the Chief of Clinical Services at Aditya Jyot Eye Hospital, which is a renowned ophthalmic hospital in Mumbai, and Chief of Vitreoretinal Services at Dr. Agarwal's group of eye hospitals. And more importantly, he is also the visiting emeritus professor of ophthalmology at Tamil Nadu M.G.R Medical University and president of Delhi Ophthalmology Society of India, which is a newly formed organization. Dr. Natarajan would be speaking on he will be delivering the keynote lecture on teleophthalmology for Blind Free Tamil Nadu 2025.
Thank you, Dr. Sendil and Dr. Shroff for having me here, Dr. Kansati and Dr. Salapar. Thank the Tamil Nadu M.G.R University for having this program. This is my dream project, Diabetic Blindness Free India 2025, but I'm going to talk on how we can have a, can you hear? Sound. Okay. On, is it on?
It's on. It's on.
Okay. So my dream is a diabetic blind free Tamil Nadu. So there's no financial interest to disclose. So we have an NGO called Aditya Jyot Foundation for Twinkling Light, which was the name was given by the former president of Abdul Kalam. He also inaugurated the van where we have the fundus camera, which was a Zeiss camera, which is a big one. In 2014, we inaugurated taking the fundus camera on the motorbike, which is the first of its kind, which is the forest camera. You can see the Tnmgrmu runs this company. And we all know that 14th November is the World Diabetic Day. The President of All India Ophthalmic Society has started this program, screening through teleophthalmology to prevent diabetic blindness called stop blindness. In Hindi, still called Jyot Se Jyot Jalao. We all know that diabetes is an epidemic happening. And this was coined by Dr. Babu Rajendran, the President of All India Ophthalmic Society. Diabetes invariably affects both eyes. Test your eyes. So IDF has found approximately 463 million adults with diabetes, and by 2045, 70 million. And which is the number which is very alarming. And in India, we have diabetics, of which 58% do not know that they have diabetes. That's where the work done in Nethralaya, in Arvind Eye Hospital. Dr. Kim is here, so many of them are pioneers, and Tamil Nadu still is the, in spite of that, diabetes affects dry blindness is happening, and that's because people don't go for checkup. So instead of people coming, I think using teleophthalmology, I hope we can prevent blindness. So we recommend primary checkup at the time of diagnosis in every person. Another problem in India is they don't know they have diabetes or not. Because at 50, they don't know. So my suggestion is that we can train people and who are non-medical, who may not be educated, but they can handle the camera so that they can check the blood sugar and maybe a AC and the retina photograph, which either use the AI offline or online, and then the data can be analyzed later so that we don't miss anything. And prevention is done here. So as an AOS president, thanks to Allergan, we made a movie which for the public interest. He's not playing. So anyway, I think that's there in the YouTube. If you put it as a diabetic retinopathy video, it will come. Just to highlight that you can just take a retina photograph and diagnose diabetic retinopathy. So the plan of action is screen, diagnose, and treat. In cancer, if you screen and diagnose and if you don't treat, there is punishment now. But unfortunately, diabetes is not there. But I think we can take our own vow as a physician, clinician, that we employ these people to do the screening and use that for diagnosis. and make sure that the people are treated. So that is why we are having an experiment in Mumbai, where we are screening all the slums as well as the Bombay municipal clinics. So the idea is to have a pre-camp awareness, assembly of diabetes, which is a challenge, and then capturing of images and uploading, and either use the diagnosis by ophthalmologist or image graders at reading center, offline AI or online. We have so many types of diabetes. We need a dietitian and ophthalmologist, multidisciplinary approach. But if you don't get the patient, what are you going to do? So better primary prevention by metabolic control, lesser rate of developing and progression of diabetic retinopathy. But the problem is to catch them when they are diabetic, and that too they are diagnosed early. Still, a significant number of patients continue to develop vision-threatening complications that require intervention, and that's where I think the teleophthalmology will be the main thing to get the people. And problem faced in our health system, as of now, we have one ophthalmologist per 100,000 population, and low awareness or ignorance. And 70% of Indian population reside in rural area or urban slums. And there are technical difficulties, unreliable internet coverage in the villages, deficit in supply of electricity in many areas, shortage of trained medical staff for conventional retina cameras, and portability of conventional retina cameras. So that's why we have come up with this. So I love this definition. Intelligence is the capacity to analyze, think, make a decision, and categorize. And that's what commonly not available. But we can use artificial intelligence, which involves formulating a specially made algorithm according to our needs to develop this capacity and include it in an electronic device like smartphones. And that's how I chose this. Again, no financial interest. This is by Remedy of Bangalore, which can be mounted on a suitable bike for transporting the screening purpose, and be mounted on any table or a slit lamp like appearance. Both the infrared device and the mobile phone, which is an iPhone, can be charged. The reason we have taken that iPhone is because at least we are able to get a standard fundus picture, which is comparable with the camera. So I coined this terminology, ABC, from the movie. Anybody can dance, but here anybody can screen for diabetic retinopathy. What do I mean by that? And we can select any pune or anybody who is just school dropout, who doesn't know to read English, but they can operate a smartphone or any interest to do that. We can give them a 3-week training and take photograph like this and send it in AI or offline AI, and then they can type. So this is like a device where anybody is an exam patient sitting there, and the examiner can go where you put the dark, and when in the dark, the pupil is somewhat dilated, and about 45% we can get good retina photograph, and rest of the 5% we have to use 1% tropicamide, and they have to have, in case if they're 1 out of 1 lakh may develop secondary glaucoma, then you have a tie to the nearby eye doctor. So that's what is one of the problem, but which is quite rare. The NHS in UK has published with millions of patients. So this is the fundus on phone. We can see the photograph, same thing taken with the size camera, and actually the picture is comparable, and that's what we are using it. And we use this AI, offline AI, where you can see the blue, which covers the lesions. There's an example of a mild non-proliferative, the mild non-proliferative macular edema, and then the severe non-proliferative with macular edema, and proliferative diabetic retinopathy with macular edema. So the main thing is to have a link between medically underserved area and tertiary care services, and you have automated uploading of images at central server and diagnose and advise regarding further management by the ophthalmologist. So we had a research question: is artificial intelligence reliable to pick out those in need for seeing an eye doctor? And this is what we published in JAMA Ophthalmology, the diagnostic accuracy of community-based diabetic retinopathy screening with an offline AI on a smartphone. And it had an excellent review. It was the first of its kind in the world using an offline AI for screening of diabetic retinopathy. We are now using the getting a non-skilled worker, give this training of using the retina camera and make them a semi-skilled health worker. And we are using them in the Municipal Corporation of Greater Mumbai, dispensary by our foundation. And this is the third year we are doing. This was the pilot study when I was the president of All India. They told why not to do a pilot study, and we did that. 231 out of 255 patients consented for prediction preferable diabetic retinopathy using artificial intelligence. It was a field trial. Average diabetic duration was 5.5 years. Patients with no diabetic retinopathy, 187 according to ophthalmologists, and we found 172 patients with no diabetic retinopathy, which means 8% were overdiagnosed by AI. And this particular publication had the maximum views in that month and the year, and it was ranked number 5 in that year. And the reliability to rule out non-diabetic retinopathy cases drops to 81.9%. But referable diabetic retinopathy cases were still correctly marked as referable diabetic retinopathy with 100% reliability if the images are confirmed. And ophthalmologists found 15 patients with referable diabetic retinopathy, and AI also marked these patients as referable cases for diabetic retinopathy. So reliability for AI for screening population for diabetic retinopathy in need of ophthalmic checkup by an eye doctor is 100%. And so the advantages, and we are still continuing, and we have now published that in the Indian Journal of Ophthalmology with a more number of patients, maybe a few thousand patients. And we are also working continuously. Still, the AI is used, and also the ophthalmologist later also compares so that we don't miss anything in the field. And the advantages of using the offline AI, early referral of referable diabetic retinopathy, greater awareness about diabetes, its effects and importance of regular follow-up, and greater care time to the retina specialist to treat the referable diabetic retinopathy, timely medical surgical intervention to prevent complete loss of vision, and more job opportunities created, skill development of less educated. And the employed youth of India, even with minimal education and no experience in retina photography, to reach out to save vision of millions, and independent of electricity and internet supply, and better chat time for the eye doctor for the referred cases, and timely treatment is the only way to prevent blindness. I request all of you to join hands for this monumental revolution, fight against blindness from diabetes. Tamil Nadu should lead this in the world. Why only India? And thanks to my grandfather, late grandfather and father, who were from the same eye hospital, which is there in M.G.R in Madras. And so my inspiration is Swami Vivekananda. Arise, awake, and stop not till the goal is reached. The goal is to reach 77 million diabetics through teleophthalmology. Thank you very much. Dr. Kim is there. Kim? Dr. Kim, can you?
Yes, sir. Yes, sir. I'm there. Thank you. Thank you for the excellent presentation, and also always driving the point that the need for diabetic retinopathy screening is very important. It's not just ophthalmologists who can do it. We need other ways to screen these patients. I know you've been driving this from a long time. It really is the need of the current time, I think. Thank you. Thank you, sir.
We have the former president of Selvakumar here and the current president, Dr. Sunil Shah, sir. How can Telemedicine Society support the Teleophthalmic Society and ophthalmologists?
I don't think so. We have different societies, sir.
Right.
Your society is our society, our society, your society. Same cause.
But all doctors have to drive this.
No, for the larger good.
Yes.
And believe me, you bring a proposal, and we may even try to get some financial, requirement if you have,
right,
which I don't usually have. But if you do have, do ask, and we'll make a proposal, and let's go for it.
Okay. So
I think it's a great opportunity for us to do something very unique in the country.
Yes, definitely. So, no, I think the cost will be for the cost of the equipment, and then we have to have a program how this one can move from the place to place, and what is his future 1 year later and 2 years later, when he gets bored of this doing this, and how do we upgrade him? So that's what I think the skill development has done. And Dr. Kim has experience, and we have Dr. Selvakumar who.
Dr. Kim sitting as the president of the TSA now, I don't think you should look only for Tamil Nadu.
Yeah.
No, I agree, but somewhere we have to do a pilot.
Why India? Why not South Asia? Why not the?
Look, yeah, at least to start.
Think big.
Being there, sitting in the chair, I think this should be focused throughout India.
Yes,
Just the
I agree. But I want to say, no, what I'm saying, I remember they traveling southern part of Tamil Nadu, but still we are having diabetics who are not coming to the eye doctor. The physicians are not referring. And instead of blaming all this, we directly go to the people. That's what we have to drive. Yes, sir.
Can I just make one comment, Ganapati here? We are actually executing this for the last 3.5 years. If you Google Mukhya Mantri EI project when Chandrababu Naidu was the chief minister of the then undivided Andhra Pradesh, we have a public-private partnership, 113 ophthalmology centers last month, and this is in collaboration with WellCare. Sendal, Tamil Sendal provides us with the ophthalmologists. We have 30 ophthalmologists from Chennai and Hyderabad. Last month, they did 1,800 remote screening from 9 a.m. to 5 p.m. We have so far done about 500,000, 500,000 retinal screening over the last 2.5 years, in 113 centers on an average of 20 to 30 per day per center. Unfortunately, Dr. Kim and others, so with a lot of help we made, but I thought it was a damn good paper. Everything we did and we sent it. The reviewers refused to believe that we have done 400,000 retinopathy screening, and they just thought it was all nonsense, fabricated, and they returned it. So this is the truth. This is the real situation, and a turnaround time is 22 minutes. The maximum turnaround time is 22 minutes. I mean, all of you are experts in this. I'm just telling you, we are actually doing it. Computer-generated report with a digital signature of a retinal specialist. This is totally free for the beneficiary. The government pays us a nominal amount as a public-private partnership. It's a contract. Of course, Apollo Clinical Services, the CEO, does a very good job of the operational details. So there is a slight excess of income over expenditure. I mean, it's not free service, no, but then it's just enough, a slight excess of income. So this is actually being done. 500,000 people we have already covered.
So there's a lot of activity that's happening on this, especially in ophthalmology. I'm sure Dr. Natarajan knows it very well. Even at Arvind, we are doing every single day more than 2,500 tele-ophthal consultations every single day. It's happening throughout the week. So, and this is not just here. In many places, people have started doing this, and this will definitely catch up. The only thing is we have to be very clear about the legal implications and the policies or strictly followed. That's all that otherwise it will definitely scale up. Pardon?
Sir, the only way to establish yourself in a global scenario is to publish. I mean, why don't you please, I mean, this is where I think, and I am sort of semi-retired now, and I mean, any help I can, I'll be very happy to help. I mean, I'm familiar with writing, editing, reviewing, and all that stuff. I think publishing is the most important thing. It's a shame that people who do 1/100th of what you people do, they are the ones quoted in PubMed and everybody. You people are not quoted because, I mean, you're so busy that you just don't have time to publish.
No, but this November, dedicated for diabetes, and Indian Journal of Ophthalmology has got publication from all of us, including the Dr. article. Wonderful. So maybe we should circulate that IGO issue, this November issue, to the telemedicine.
Can I just ask Dr. Professor, have you already started the panel discussion?
Okay.
Have you already started? Because this is like a panel discussion.
Okay, Dr.
But you're the moderator for panel discussion.
Yes, I know.
But Ganapati also is supposed to be on the panel.
Just a comment.
Yes. So we are telling, we have started the panel discussion.
Most of the people, again, who are sitting here, it's all from the private side. Please understand.
Yes.
I've been keeping on.
May I just?
And I'm keeping on insisting on this. Unless there is an involvement of the from the government side.
Correct.
And they are the people who are really taking the mass. So I was always saying, you need a proper nodal officer or chairman or something.
Your point is well taken.
Yes. Very important to take it to the mass. Without the government support, you can't do it. You can do it to one level.
No, that is the reason.
If you want to reach to that level of what we are trying to start,
Sure.
the government involvement must be there.
Yes. I agree with you. That's the reason we have to make a representative to the government, and Tamil Nadu government, probably a lot of people are close to the minister, so we have to.
Can I just interrupt if you don't mind?
Yes.
So shall we go on to the panel discussion?
Yes, sir.
Telemedicine in Tamil Nadu, which is already started, by the way.
Yes.
And Professor Natarajan is going to moderate it. Dr. Kim, you are still there, I hope?
Yeah.
Yes, sir, I'm very much here.
Dr. Prabhu Rajagopal, are you here? You're just on time, good.
Yes.
And Professor Kumar, all stalwarts. On you go, sir. Panel is on to you. You have about 20 minutes to to see how to promote telemedicine in Tamil Nadu.
Yes.
You already completed 10 minutes of your panel discussion.
Yeah, okay. So, sir, since we have Dr. Prabhu
is
from, no, I know, here, Dr. Prabhu, you have to speak a little louder. People like Dr. Kim from Madurai.
Come here, next to Dr. Sen.
Yeah, okay, you can come here. So Dr. Prabhu is from Indian Institute of Technology, and probably I'll request him to introduce himself and then start the panel discussion. Mike is there. You'll be seen because all of us are seen.
Yeah.
Yeah.
And we also have Dr. Chandra, Dr. Ganpati, and Dr. Kim on online, and they are all here.
I can speak normally. Like
yeah, you can speak little so that yeah.
So good afternoon, all of you. It's a lot of joy for me to be here among eminent speakers. I am Professor Prabhu Rajagopal from the Department of Mechanical Engineering at IIT Madras. My usual research is in the topic of sensor data networks. I work on securitizing large infrastructural assets such as bridges, dams, wherever you have river crossings and so on, and also in the industrial context such as plants, power plants, pipelines, and so on. So that's my usual area of work. But what brings me in connection with doctor is because recently I've been applying similar concepts in the area of healthcare, where we've been trying to securitize large data sets in the context of digital health records using blockchain. So blockchain technologies bring a level of trust and immutability to records. So we've been trying to see how we can securitize and also bring a lot of assurance to medical personal health records. Yeah.
So in this, like telemedicine, one is, I mean, we are not one, there are many in this panel, we are ophthalmologists who are more here. But generally, we are discussing diabetes and diabetic retinopathy. So one of the things we have is how do we reach 77 million diabetics in India? And Dr. Kim's favorite thing is about how do you protect the identity of the patient, because you can use the retina photograph to identify a person, which, how do we mask it?
Yeah. So, yeah, as far as telemedicine is concerned, based on my work, what I can say is one of the big bottlenecks, at least all over the world, in India it is not still catching up, is privacy, data privacy, right? So telemedicine involves storing large amounts of information remotely, and typically in centralized servers, actually. So this kind of data is very easy for hacking. I'm not saying it is very easy because there are advanced cryptographic tools available, but hacking incidents have been going up all over the world for the last several years. And personal health records, for example, in any context, particularly in telemedicine, are vulnerable actually.
Yes.
And therefore, I think securitizing them is a big step in easing the concern of people as such. That would be.
So how do we do that?
There are a range of ways in doing this. Today, there are already cryptographic techniques available by which, for example, the CoWIN portal is a good example, and it's served in a very, very smooth manner. In a country like ours, more than 1 billion people, we've all been able to log into this portal and also be able to make use of this data. And so far, we don't know what is happening in the background, but at least there have been no reported incidents of hacking on this platform. But I know what is happening in the back end because I'm in touch with the team that has created this portal. There's a lot of advanced cryptography that has gone in, and that is what is assuring this data, security of this data. I think that is available today. So if it can be done in a platform that is, as widely available as CoWIN, it can be done in any platform. That would be my view. Yeah.
Yeah, I would like to add one comment. Because your question was on how do we reach those 70 million diabetic patients. The biggest challenge is on the cost of equipment. So maybe if IIT can, because they have the incubation center, and if you can develop low-cost device, maybe at the range of 50,000 rupees, I think, which can screen the retinas. I think that is when we can reach 70 million people.
It is possible, sir. So costing is usually a product of market. It is not a product of technology. Any product can be made very affordable in that range, provided there is a huge market for it. You know, the cost is high not because the technology demands that the cost is high. It is because there is no market for it. If we popularize it enough, if there are enough takers for a technology, I'm sure that the cost can be brought
So that
down.
is where Dr. Selvakumar's point is, health is a state subject. Every state should take it up. Sunesh, you had a question if required for money. The problem for money requirement is more than internet. I think now is the cost of the equipment to take a photograph of the retina. And also the other data is easy to get.
Yeah, I know, you're right, that is a challenge.
He's selling from 4 lakhs, make the camera to cost of 50,000. And maybe that operator also will need a minimum wages income, maybe 12,000 because you have some skill. So you have to tell them.
The challenge is if we can get this going, mobile, and if we can screen retinas through this at some stage, I know that is difficult. I know that we dilate the and add it before you can actually see the retina properly. But at some stage, I'm sure this is going to happen. Many people are still trying. I think that is the pain point. The cost of the camera, at least in developing countries. I know the cost in India has come down compared to the ones which are available abroad. The cost has come down to about ₹1 lakh. I think the remedial is not that expensive. But even if the cost can come down, you can do self-screening if you can and send a picture. And that will be where you will have a huge number of patients coming in.
Sir, can I say something?
Yes, Kim.
No, I don't agree completely on this. It's not just the cost, it's just the mindset and the whole process being set for everybody. Today, nobody is doing it because they don't feel it's necessary. So that has to change. That mindset has to change. The cost, which was 8 lakhs, is now available for 2 lakhs. Why people are not taking it still? And Dr. Sendil has shown a beautiful revenue model that he has established. And if that can be extrapolated to shown to people, I'm sure there are so many other diabetologists or endocrinologists will take up this model of telescreening to a greater extent. So that it is not just the cost of the camera. It's ads there, but that is not the main reason. It's just the change in the mindset of people to accept this.
I think, Kim, what you are telling is the same as Selvakumar reiterating that government has to be a partner in spreading this message across. So I think that's the reason I'm suggesting that Tamil Nadu government, a lot of people are close to the current government. And I think like Mohanrajan as president and you as a part of the Asia Pacific Teleophthalmic and Teleophthalmic Society plus the telemedicine. So I think we have to make a representation to the government of Tamil Nadu.
Tamil Nadu government has put fundus cameras in every hospital, but it is not happening. The screening is not happening today.
I know, correct.
The government has invested in it. The policy has to change. Somebody has to make it mandatory, then it will definitely happen.
That's the reason why I said a nodal officer and the chairman, someone like initiator has to come,
Right.
Now, so many telemedicine centers and governments kept locked for a couple of years. They've not even opened it.
Yes.
What equipment has been locked and kept.
Right.
That has not been opened. The institutions are still there. I know several government institutions, all the equipment has kept closed.
As is.
Years. Not open. You can see.
I mean, having a nodal officer is a great idea. This is exactly what we did in transplant for solid donation. We have a nodal officer who is in charge.
And he should have been here today with us.
For transplant, yes, he should have been here. So for transplant, we've done that and that has worked. In fact, we have a nodal officer even for police cases in our donation. That has really eased a lot of pain points.
He was mentioning about a nodal officer.
You already there.
IAS side, you will directly be in touch with the government. I'm not talking about that. I
know, for day-to-day.
Day-to-day work, who can be like, I mean,
I like a director of
telemedicine, Ramchandra. That's the reason why I sit and talk, and that's the reason why I do what happened. That's what Ganapati did for Apollo, and that's what I Kim. Same thing should happen.
I agree totally.
So they have a director of telemedicine.
It should come from the doctor's side. Art of the official side, it doesn't work there. Official nodal officer, what secretary was mentioning is an IAS officer who's a nodal officer.
Yes.
That's not going to work.
And he has his faithful always.
He's already got so many other things.
That's not going to work.
It's not going to work. You need someone specifically for this purpose. Not by need, by, you know,
Position.
He may be transferred or something. Someone has to go on, because these telemedicine centers, I know more than 10, 15 are kept closed, not open.
I think one of the barriers is this differentiation again with the public sector and private sector. I know there is a trust deficit in private sector, but 90% of healthcare, to be honest, I know government of India is spending a lot of money, but if you look at the GDP of health in India, it's close to 5%, of which about 1% is only from the government. Rest is from the private players. So private players are playing a large role in delivery of healthcare today in the country.
Public-private partnerships are coming up. We can't, it's not zero. No, we ourselves are an active role in 6 governments. About 12,000 consults every day we do for the government. That is for government.
You're wrong.
Partnerships are coming.
Yeah, because it's happened because in COVID times.
No, this happened before.
Yeah, okay.
This happened 5 years.
I'm trying to say that, we need to have, when it comes to somebody at the helm of affairs, it need not be somebody only from the government sector.
Yeah, I think PPP
That sir, don't you public SGPGI as a school of telemedicine. We should have 3 schools of telemedicine. 6 times. Right, sir? How fund it, sir?
No, but not guy.
But one day,
I think Vidya wants to know.
let's give them a chance.
Because Saroj Mishra first.
Saroj Mishra went in all the way and asked for it and given several crores of money to give it. And it's been, that's the reason why I said someone has to be in the government.
I agree. Vidya, you want to?
In the context of public-private partnership, I think in the last 10 years, at least going door to door to various government offices, I can clearly see that today there is a lot more acceptance and trust built with private sector people, but definitely you need a mad person behind it who will be consistent in making this engagement, saying,
Most of the people in this room are mad.
We need 100 rooms like this.
Yeah.
I need people who are consistent, but there is an opening. Let's see, because this, and more so, they're also willing to give money. We take money and more, they're even more willing to integrate us into the government system. So we just need definitely requires a lot of persistence.
Like in Odisha, the first year they gave 1 crore. Second year they gave 2 crores. Now they've given 5 crores. Government is spending every year for telemedicine for the government. That budgeting has to be.
The key point, the key thing,
Government also has a budget.
But
Karnataka has a budget.
the key point is, sir, that the private parties will be trusted by government if they have a track record. So like, for example, on vaccines, the government is entirely gone private. It is not said that, we will produce in our own factories. They have worked with a lot of private players because these are all credible players. Bharat Biotech already has a record of making vaccines that are distributed across the world.
Credible players in the private sector in telemedicine. Enough.
Yeah, so I think then
In fact, we are much more, 90% is in the private sector. 99%, it is people here who are permanent.
That's the reason why they conduct this conference in the university.
But
Very
they
simple.
credible.
So credibility, no one has more credibility.
does it require a triggering point like COVID then?
It has required a triggering point like COVID. If it wasn't for COVID, the telehealth ecosystem would have come so far, believe me.
Now, during the COVID, government opened many telemedicine centers. The conferencing, audio conferencing. What happened to these things? I mean, now they're all practically like required. They're not being used. I know in corporation, they had 50 people working for telemedicine, and then people used to call them. So, but that has to be taken for wellness. See, unless that is being continued, now what they use in the same center is wellness center. It's changed to wellness center. Same thing that we do.
That's probably because government, they definitely don't want to put hands into one aspect, they should use the board. But this not using things beyond COVID is true all over the world now. Wherever telemedicine picked up only because of COVID, all those places it has reduced or stopped something COVID. Only people who are paying even before, it's still continuing because there is already a mind behind each of those.
There is a certain amount of resistance even from doctors actually though. You know, when you say, doctor, I want to consult with you remotely, in 90% of the cases they say, can you come in person? You know, so
It's partly because of the business model. Until recently, it was very difficult to collect guidance providers from a patient 900 miles away, collect it and give it to the doctor.
now with the help
Now that whole problem has been solved.
yeah. But even now,
Some models were running very well. For example, the demands planes I can.
come again, sir. What model?
So well, and they given to several other states, not only within Karnataka, but they expanded to Jharkhand and so many other states. They're doing hundreds of consultations for psychiatry. So the ultimate need, how many psychiatrists we have? 5,000. We need 5 lakhs. We have only 5.
That alone is because of a champion Suresh.
Again, you have a champion.
My philosophy is 21 years experience. We need to build champions.
Yes.
In every district in India, we need a
You mentioned about CVT. Government of Odisha has given 32 district government hospital laboratories to my company to run the laboratory. I run 32 district government hospital laboratories. That Odisha, which is so backward, they don't even have HbA1c. So every nook and corner of Odisha, we are doing HbA1c and PPP can go. Good companies available in telemedicine, like Ramachandra is there, Apollo is there. We can sacrifice on the PPP. Government can give the PPP to us, and we can do the entire state. And it is possible. Even if the model has to be worked out. A nodal model is one proposed, one PPP model, a couple of available. Definitely, it is approachable, doable. But as he said, it has to be a collaboration with the government. Government should open the requirement of PPP. Only if the government open the requirement of PPP model for delivery. So anybody can go and apply.
What about this Ayushman Bharat, sir? I mean, is there a telemedicine?
140,000 wellness centers, each one of them is going to have a telemedicine center. For 3,000, 4,000 are already working. Next 5 years, 150,000.
Ayushman Bharat telemedicine has to be in private partnership with somebody.
And managed by.
Everything will be
So Ayushman Bharat is
Clearly, easier to send, a very, expensive equipment to a village than send a doctor. And the government of India wants the technicians to manage those centers and perhaps Ayush doctors if they are willing. And then do consultation and create wellness centers. Let's see how far this succeeds. Each state have 1,000 such centers. You already have 150,000 primary.
So why don't we leverage this in the state?
Any questions from the audience? And in the meantime, any comments or questions or any criticisms? In the meantime, I think I want Sendil, you started the discussion of 77 million. How do we do like Ganpati said, you mentioned in Andhra you have done. And why don't we do it in Tamil Nadu?
Actually, what we felt was it is easier to do the private way rather than.
No, I'm telling you the private way only. How do we reach the villages? So what is that?
The villagers come to a government of Andhra Pradesh Teleophthalmology Center. My staff are there, he helps. So villagers do not come to Apollo. They please understand that this is being outsourced by a tender to a private company. So because we are damn good in the operational, we are able to implement it with a downtime of less than 1%, 99% efficiency.
And one more thing in the Andhra project is it is done in the community health centers where there are already hundreds of patients coming in.
Infrastructure. Added a little bit here and there.
And all the patients also get free glasses. So if not for retinal screening, they come for the glasses also.
Yes, Kim.
Yeah. No, I just want to share. You are saying that all the PHCs, the diabetic patients come to collect medicines for once a week. So in Teni district today, we are ensuring that every diabetic patient who comes to collect their medicine gets their eye examined. If that becomes a policy by the government, that only if you have your eyes examined, you get your medicine. It is made mandatory through telescreening, then it will be definitely you will be covering much more people in this process.
Yeah, I think
that's what we are doing in Bombay Municipal Corporation. All the 55
lower number of ophthalmologists. Medicine is not only diabetic.
No, I agree. No, sir. Through the eye, you can see the whole body, sir. No, really, no, you see the vascular system, the neuro system directly. Nowhere else you can see. That's why Google, Sundar Pichai has mentioned you can use Dr. Kim's data, you can predict in myocardial
area of telemedicine in special which will grow, which has already grown, of course, is in India, a lot of.
Dr. Ganpati sir, Dr. Ganpati, Dr. Sunil said all societies are same. So whether it's ophthalmology is a branch of medicine.
It gives me back. So tele ICU has been a new kind of huge growth in the
We
scene.
are one of the largest in
COVID times, and I met a few ICU consultants who are only working in tele ICUs, who are not doing any other practice, were sitting at home and monitoring the remote ICUs in Bihar, in Uttarakhand, and so on. And that's another growth area that will happen. Of course, tele-psychiatry,
medicine is one of our most active consultants is sexual medicine and rheumatology. Our rheumatologist does about 2,000 a year. He has done almost 20,000. But the reality is, he has just not documented, no data, vague data, not enough for a prospective study.
I think, overall, in Tamil Nadu, the opportunity is there. Tamil Nadu healthcare.
As in input from Selvakumar and Senthil has to come out with a business plan, which is different from Andhra Pradesh. And how do we reach the people? Because I think, I agree with you, one side with the Dr. Ganpati and Selvakumar will work with the government, and the other side, ourselves through the PHC, when they are coming for diabetic medicine. How do we get revenue for you?
Actually, the PHC model, only if the government invests. Somebody has to pay.
Exactly.
So can we now finish the session? Thank you very much.
Yes, thank you, sir. Thanks for that. Thank you, Kim, and thanks, Prabhu Rajagopal.
Waiting for the Vice Chancellor to come, and she's still engaged and she's coming, and we still have some time. I'll take 5 minutes.
Selvakumar wants to make a comment.
Yeah. There are some big private companies are ready to sponsor it. Them and give them the tax benefits. They are the companies with really CSR responsibility. We do something. CSR.
We can do that with use. What I'm saying, you have to make a business plan where you take your company, whatever is your profit, and some other company can own or do it, and then
go up for a tangent. I think the topic of this panel is business.
Yeah, Tamil Nadu only.
I am suggesting every 2 months you must have, and I thought your idea was an excellent idea 2 years ago when we went to Nigeria, when we went to Brazil. I think instead of having these conferences in all these places, we should go to all places in Tamil Nadu, have a full 1-day program, and at the end of the day, IMA will report for it. So IMA, we do this 4 times a year, 5 times a year. I think it'll have a lot of effect.
Alternative therapies which didn't really come up.
This telemedicine is not. There are regulations for Brahmani, Ayurveda, Siddha, and homeopathy. They are passed by the respected government council, and people are using it. So, we have to take it alive. Psychiatry in that way is very progressive. They have made their own guidelines approved by the Indian Psychiatric Society.
Post-COVID, mental health has become a big issue. Big
issue, and people, it's not poor or mental health, not poor or rich. Both equal. We see that it's not the poor. Big very psychiatry will play a very
big role. In fact, it's already doing that.
Also,
we can
Chief Secretary interested health
secretary. Society.
I think I'll show you the course we have developed. Just give me 1 second. Just try to I hope you're able to. Let me just do my sound. That.
Yeah, sure.
So when you, Dr. You have to switch off all your mind. And have a look at it. I will give you access to this to all of you. Your comments to it. Short M.G.R Foundation, which is an organ donation NGO. We've been promoting it for the last 25 years. We are running online courses for the last 10 years. So when the TSI started to do training program and made me the head of training, after September, we didn't have any activity and it was felt that we should go online. The experience with M.G.R Foundation, the M.G.R Foundation team helped me in putting the short courses together, and we managed to get a small grant. Everything costs money from a company with which I'm associated called Meditech. So these courses are pro bono given to Telemedicine Society of India, and we have had now close to 300 candidates who are taking this course online. Every day we get sign-ups. So this is a TSI website, and you just click on the TSI courses, and this is a foundation course link. You click on that, and you'll get to the foundation course. And you see this is your, if you want to take the course, you just click on this course link here, and it will take you to the form which you need to fill to give you a number of MCI and so on. So that this course is only for registered medical practitioners. Yeah, okay. And this is a short introduction. We have a video which Dr. Kim had played earlier. I'll try and play again. I just want to show you, Adam, just 3 minutes. You come at the right time, Adam. We're talking about the short courses of Telemedicine Society of India, which we've developed. I just want to show you what we've done online. It'll take me 2-3 minutes, and then please, madam. So you go to the TSI website, you come to the link, you click on the link to register for the course. There's an application form. This is all online. There's a short video to explain to you what the course is about. And then you have what's the modules you have. There's a pre-assessment. The structure is that you do 20 minutes of pre-assessment to know how much you know already. Then there's an introductory module on telemedicine, which covers the brief history, definitions, acronyms, telemedicine practice guidelines of Government of India. And we have, in every module, we have 2 video modules. So we have 2 lectures here on telemedicine practice, basic understanding of teletriage. And the second module is about legal and ethical aspects of telemedicine. Again, we have 2 lectures here on ethical aspects and medical legal aspects. Then how to set up a telemedicine practice. That's the third module. Again, there are 2 lectures. Triggers, etiquettes, and tips for telemedicine. How to do a consultation. How to set up a telehealth consultation. And then there are optional reading modules. That's the 4th module. After that, there are asked questions, live interaction with faculty once a month. Feedback. Then they get if they don't get a certificate, otherwise they get a completion certificate. Assessment here as well. This is again online, which takes them 40 minutes to complete. So we have started the foundation course. This is the foundation course, which is running, and I'll show you how it works. And then we have a course on diabetes, and we have pediatrics, and one for Ayush. So these courses are already available. Now let me show you the course, how it actually is, if you can. This is a short video on the course, madam, that we try. I need some sound.
Hello.
So this is a very short video of the course, and I'll show you the actual module. And we've had some excellent feedback on the course from the participants who have actually taken the course. Am I still sharing the screen? No. I'm sharing. So we train some army personnel doctors, and these feedbacks have been very good.
I think the screen is still not shared.
I did. There it says here.
Just press that.
Oh, okay, I'll share again. Webex is a chat. So we've had good very, very, so we good feedback, and if you see the overall satisfaction with the course, now almost 79% have said this excellent or very good. And you know, you know, very good feedback.
Shrav, we are not getting the audio.
Had almost 300 participants. So, yes, absolutely. And I'm I should go to you. Refuses to.
Raji, and all the other dignitaries, various vendors from various telemedicine, ophthalmology societies. I thank you very much for making this happen in this university. The university is very happy that could have this webinar or a kind of hybrid in the premises of the university. As Dr. Radhakrishnan was making a mention this morning, the advantages and significance of telemedicine are well understood. Dr. Kumar was, if I remember right, narrating the history of the Telemedicine Society of India and its Tamil Nadu chapter. The history of telemedicine as such is supposed to have started sometime in the 19th century. And whenever there was a kind of a teleconsultation, not necessarily utilizing the technology platform, but then using the simple communication device called the telephone, I believe it was still part of telemedicine, a kind of a telemedicine, maybe in a micro-constituent form that was going on. As rightly pointed out by many of you, COVID pandemic made us understand the significance of telemedicine further. I've always wondered at the kind of telemedicine being practiced during the pandemic amidst the physical ambience. All of us know patients were admitted. They were there physically in the hospital. The medical and paramedical personnel were there physically in the hospital. Nevertheless, healthcare was delivered either through the robo or through a video call or some kind of technology platform. COVID made us understand that physical proximity as such need not be there even in the physical appearance. That way, yes, post-COVID scenario has changed. And as rightly given in the theme of this webinar, there is so much of potential available. However, I would still differ to say that this is untapped potential. In the sense, if you decide to have another webinar maybe 10 years later, you could still have the same theme, telemedicine, the untapped potential, for technology keeps growing and expanding, and there will always be some potential left out in an expanding technology. One difficulty that telemedicine might face in a country like India is that apart from sensitizing the medical fraternity, apart from sensitizing the educated lot, we probably will have to sensitize the end use, the so-called end user or the patient in a rural setup in a country like India might still feel that the doctor is not available, is looking and giving guidance from elsewhere, maybe even extraterrestrial kind of area. The patients in that case are not very comfortable with what is being given across the technology platform. A part of it was seen even during the COVID pandemic. I, for one, experienced it firsthand in the sense some of my friends who were hospitalized because of COVID would call up late in the evening and say that they feel left out. They feel completely depressed because the doctor did not come and see them that day. My immediate response to them would be to ask them if there was a video call. The answer would be in the affirmative. What else do you want? No. It's fine, the doctor saw me through the video call, but then nobody came near. Now, this is the reaction, not only because of COVID, but a general kind of a reaction where the patient feels that there is no physical proximity of the healthcare person. So probably to make the potential much more accessible, we would have to sensitize our patients more. This, I feel, is a very important aspect, and unless we make them sensitive to what is available, making them access this facility may not be complete. There are two other impediments which are talked about. I think those two have been at least to a large extent overcome. One is the connectivity infrastructure. The other one is the expense. With COVID, the connectivity infrastructure, various kinds of platforms, various kinds of applications have become available, and it is possible to use them further, maybe develop them further for specific purposes. But then there is yet another impediment, which was of course mentioned by the Principal Secretary Health and of course a few other speakers too. The legal issue involved. Legal issues including patient confidentiality. Probably the regulatory agencies will have to be made sensitive, I'm sure. Many of the experts here are also part of the regulatory agencies. The regulatory agencies may still be working with some archival rules and regulations. It is time that we modify them. But before modification, much water will have to flow under the bridge. More discussions are required. And what exactly is patient confidentiality, or what exactly is the area of litigation? All that requires to be discussed. I wish at some point of time the Telemedicine Society of India's Tamil Nadu chapter takes up a discussion of a larger scale, a discussion that involves more stakeholders, the general public, the judiciary, the legal fraternity, the print and the visual media. Now, all these are the stakeholders in making a program of telemedicine successful. If only we can take it across the state and across the population, I suppose the stakeholders will have to be involved. I am very happy that this webinar was extremely informative, educative, as I could see from the remarks which have come in the chat box. I only wish that this is taken forward. This university is open for academic discussions and work always. So we would take it forward from our point of view, but I only request, let's involve a larger group of stakeholders and probably plan something wherein we really tap the untapped potential that you've been talking about from morning. All the best and thank you very much.
Excellent overview of the proceedings of the day and your views. Much appreciated, madam.
Thank you.
And thank you for giving us an opportunity to be in your campus, despite all the weather, prediction.
This is, I suppose this is the campus of the medical fraternity. So.
I request Satish to propose a vote of thanks and then we have lunch.
Good afternoon, one and all. Just really we plan to organize this conference as an eye-opener or curtain raiser to the beginners of many strangers in this field actually. But in fact, this we structured in a fine way. This is one of the wonderful CME program or webinar, we may call it. Usually just we organize the conference in at least a month to take. We organized since recently just we organized a national level conference. This conference was organized just within 3 days. So that our organizing committee, keeping in mind with regard to that stance, bringing the stalwarts in this field. So they were brought that many stalwarts who is joined in the faculty, almost more than 2 decades in this telemedicine activity. And the lectures were standard, highly standard, delivered by the eminence. And it's really just we are, as a Telemedicine Society of India, Tamil Nadu State Charter, we are trying to promote telemedicine in a big way. And 4 years before itself, we organized a telemedicine at this institution. Just we would like to thank the Principal Secretary spending his precious time coming all the way in spite of his busy schedule. As well, we would like to thank the Vice Chancellor of this esteemed university, Dr. Sudha Shashian ma'am. First of all, just we would like to accepting our invitation to conduct this organization, and she extended all her possible way to conduct this program in a fine shape. And their assistant Pushkala ma'am, as well the registrar of this institution, and extending our sincerest thanks to all donors in the field, Telemedicine Society of India and Telemedicine Society of India, it's state Tamil Nadu. I may be excused if I forget any name. And on behalf of TSITN chapter, I would like to once again thank the entire team for organizing this better program in this premises. Thank you all. And I request the entire team to join lunch which is organized at outside dinner, outside premises. I would like to thank that, I'm sorry, I would like to thank that many directors, deans, and medical superintendents, as well the administrators who have been participating outside, through virtual mode. Thank you, sir.
Thank you.
Thank you, ma'am.
Thank you very much. And for those of you who are part of the university webinar series, as we announced earlier, 19th of November should have been our regular webinar. Since the Telemedicine Society planned a webinar, we thought we'll club university webinar with this. One other reason we thought this could be in the forenoon session and not the regular afternoon session as far as the Indian timings are concerned. Today being the Kartikai Deepam festival, we thought people would want to leave in the afternoon. So that is one of the reasons that we decided to have this in the forenoon. So thank you very much for cooperating and being with us. The next edition of the university webinar series will be on the 3rd of December at regular time of 2 p.m. or 2:30 p.m. Indian Standard Time. 2:30 p.m. Indian Standard Time on the 3rd of December. We meet again, and thank you very much from the Tamil Nadu Dr. M.G.R. Medical University and the Telemedicine Society of India. Thank you.
Thank you.